Good morning, everybody. Morning. Welcome to this beautiful day. I said if I had to work here, I would never get anything done. It's like gorgeous out. Now I get the golf thing. I don't play golf, but this is beautiful. So, my name is David Nemiroff. I am the board chair of the Health and Welfare Council, and I wanted to welcome you all here this morning. So, we have a wonderful day set up for you. And Rebecca and her team have done an amazing job of bringing in individuals from government, from nonprofits, leaders, from people around the country, even from our guest keynote from California, to really address health equity. So it's going to be a very interesting day. Before we get going, though, let's recognize some of our key stakeholders who are in the room. First, again, the board members of the Health and Welfare Council. I want to thank you for your support if you're here. Just give a wave, but thank you guys from the board. Appreciate that. All volunteers. I think we're supposed to have representatives from the governor's office here today, so Imran Ansari and Teresa Santaro, if you're here, thank you for coming. We appreciate it. We have somebody from the Department of Labor, Brian Sabb. We're supposed to have a state representative from Senator Monica Martinez's office, so thank you for being here. From Suffolk County Executive Steve Ballone's office, I think we have Steve Randazzo should be here today. From Nassau County Legislature, we have Legislator Sheila Bino's office has somebody here, and the Town of Hempstead Councilwoman Goosby's office also has somebody in the room. I think we have two health commissioners here today. And if Dr. Eisenstein knew I was going to be here, he probably wouldn't have come. But thank you, Dr. Eisenstein from Nassau County, and Suffolk Commissioner of Health, James Tremarkin. Thank you, Doctor. We also have Acting Commissioner for DSS in Nassau, Paul Broderick. Thank you for coming. From Sandy River, we have Nate Barry. We also have folks from the New York State Department of Health. And later we'll have some other elected officials who will serve on some panels. I think I saw the controller last night who's going to be here as well from Nassau County. So we've got a nice group of individuals, we've got a good room, but I wanted to talk just for a second about health equity. So not only am I a board chair of the Health and Welfare Council, but I run a nonprofit organization, a federally qualified health center, and we deal with the issue of health equity every day. So we serve about 40,000 people in Nassau, and about 25% of those folks don't even have insurance. So I'm dealing with about 10,000 individuals in Nassau County, wealthy Nassau County, one of the healthiest in the country, and yet there are people who don't have access to the same health care that maybe everybody in this room does. And that's a challenge. And so I'm hoping today to learn a little bit more about what I can do as a healthcare leader. I want to hear from the panelists of how we're going to do to improve those health equity and improve those outcomes. So unfortunately, there's some new assaults on the federal level with regulatory challenges of how we care for people from the public charge and other rules, which makes it more challenging instead of more cohesive. So I think now more than ever, coming together, sitting here as a group to understand about health equity and how we can work as a community to really support Long Islanders and raise us all up is really important. So I just wanted to thank everybody for coming today. I think it's going to be a wonderful day. Thank you again, and Rebecca, you want to lead us off? Thanks, guys.
I just have to move the microphone down. Thank you, David. Before we get started, my staff would be really mad at me if I don't tell you that you can live tweet today, and the hashtag is LIEquity19. So please do so. I don't know if Tori Cohen is here yet, but if she is, it's her birthday, and we want to wish her a very happy birthday. Welcome, everybody. We are so excited for the day ahead, and I thank you for being here. In addition to thanking Health and Welfare Council of Long Island's board, I want to recognize my team because they worked so hard, and they worked so hard on today's conference, especially Emily Rogan, Lori Andrade, and John Lopes. We have an exciting day ahead, but I must now shift gears to set the stage for today's event. We live in the most segregated region in the country, America's first suburb, a region with promise, but not for all. There were systems built to make sure the promise wasn't available to all. Restrictive covenants to keep homes all white. And Robert Moses, for whom our beaches and our highways are named, urban renewal and actively discriminated in regional planning. That was 1947. Discrimination was codified, engendering the systemic racism that endures to this day, despite increased diversity. The Long Island that we live in guarantees that zip code largely determines health outcomes, educational opportunity, social mobility, and so much more. Systems are powerful. In 1910, Theodore Roosevelt said, "It is not the critic who counts, not the man who points out how strong the man stumbles or where the doer of deeds could have done better. The credit belongs to the man who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who at the best knows in the end the triumph of high achievement, and who at worst, if he fails, at least fails while daring greatly." We are here today to talk about powerful systems, and we are here to dare greatly. The truth is, many people in this room are leaders and stepped out of their comfort zones in joining our Health Equity Alliance. And quite frankly, there are many of you who have been doing this work, fighting against inequity for decades. Organizations and leaders who look at the opioid crisis with frustration because they've been fighting addiction for decades in communities of color with a fraction of the resources and a fraction of the attention. And I live in awe of the resilience and continued fight. And the thing is, I've learned that if we want to have progress, we have to show up for each other. It's why our Health Equity Alliance, we've learned how to work differently, how to do things differently, not only how to share information, but how to build a better system on Long Island, and to do so by harnessing the wisdom of those who have been in the fight a long time, and those whose hearts are simply positioned to better our region. And I'm gonna be real. If the definition of insanity is doing the same thing over and over again and expecting a different result, then this conference today has to be the catalyst for recapturing our sanity. And in doing so, we can recapture our humanity. So what do I mean when I say our current circumstances are insane? We must again revisit the past. What I mean is that Long Island has developed from exclusionary principles. We know this, and yet we do the same thing over and over. We continue to exclude and fail our communities. As we continue to diversify, we make no real progress. We are fragmented. Long Island has 2 counties, 13 towns, 95 incorporated villages, 124 school districts, and quite frankly, I could go on and on. Someone could walk into a county agency for help with one thing and never find out about all the other services that could benefit them nearby. And despite the amazing work of our Health Equity Alliance, we have so much work ahead of us to eradicate this kind of experience for all of our neighbors. And let's be clear, this happens to people with resources and people without. Our fragmented system fails all families, but those in need disproportionately. Long Island is thought of, even by some of our officials in Albany, as the land of great Gatsby, of opulence. But the reality is we don't have pockets of poverty, we have pockets of wealth. Yes, when you look at our percentages to understand who we are, we look okay. With about 6% in Suffolk County and about 5% in Nassau County of folks without health insurance, for example, it might not sound that bad, but it means that over 125,000 Long Islanders don't have health insurance, and many more are underinsured. We continuously have conversations about the challenges in the nonprofit sector and government. Those of you who are doctors, psychologists, pediatricians, you have these conversations all the time, and they are frustrating. It is frustrating to spin our wheels while human need grows. But here's the really insane thing, the audacious thing. There are indeed solutions. Other states are doing a much better job than us, and through their examples, we may find hope. But hope doesn't pay for the system, the infrastructure, that we need to move the needle and to stop accepting the idea that a child in Hempstead can have radically different outcomes than a child in Garden City as determined before pre-K. If we keep accepting the lack of infrastructure and we don't demand the technology to track human needs and meet people's needs given our segregation, how many more generations of crisis are we going to be complicit in observing? How can we see that? How can we see one another and not act? How can we be complicit? And when we say the system is broken and we don't act to change it, we are all complicit. The state invested millions of dollars all across the state to plan, to help organizations better serve people as part of the movement of Medicaid reform. Here on Long Island, we did that. We came together and we planned and we found out that our fractured systems will not work if we don't have a strong data sharing platform, a strong infrastructure, so that if the young woman that I helped last week gets released from the hospital that is stabilizing her after she attempted to commit suicide, is given a referral for care, that we can know whether or not she made it. We can identify what other needs she has, and we can share information in multiple directions with the entities that serve her. If a client has diabetes and can access their insulin, but has to buy off the dollar menu at Burger King because of lack of access to healthy food, that doesn't work. And if a patient with mental illness can access care but lives in a home with domestic violence and doesn't have transportation to their community college, that doesn't work either. Imagine a world where managed care organizations, health systems, criminal justice systems, education systems, nonprofit providers all share information. A world where human service providers were not dictated to by managed care organizations, but actually had data, had power, were able to protect their clients. For one precious moment, please imagine that universe. For this to happen, we need two things on Long Island. We need an investment in infrastructure because technology is key to peeling back the geographic limits of our segregation and serving all communities until and even beyond the day when Long Island is desegregated. And we need the state to mandate that managed care organizations partner across the human services sector to meet all human needs. When we built Long Island, we designed a system that has meant that the community that you are born in can be your greatest fortune, or it can be tragic and underserving. And now, since we have no way of sharing data, and school systems and criminal justice systems and nonprofit systems and medical systems don't speak to one another, in 2019, we've created another system, the system of benign neglect. And there is nothing benign about the amount of people that are hurting in our region. We need the investment in an infrastructure that allows us to see our clients and their needs and meet them and track them and understand them. Each of you in this room, whether you are a psychologist or a pediatrician, a government official or a healthcare provider, a nonprofit leader or a researcher, you need this data. We are here today to dare greatly. And I'm going to dare greatly and say that we have a long history of systemically failing people on Long Island. When over 10,000 children came to Long Island since 2014, unaccompanied, we watched them be criminalized in the media, and yet we never saw an increase to our schools to meet the pre-migration, migration, and post-migration needs of children who want the same thing that all children want: public safety, opportunity, hope. We have no way of knowing who they are or what they need, and yet we have over 10,000 new neighbors living invisible lives. We can't be okay with that. There was no investment, and our schools and communities have done the best they can with nothing. The State Department of Education did not increase foundation aid. Nothing radical was done to protect, to honor, or to serve these children in the communities in which they live. Do more with less? Sometimes you just do less with less. There's a term you will hear about today that has become trendy in the healthcare system called social determinants of health. It is a term used to describe the parts of a family's life outside of healthcare that play a critical role in health outcomes. Things like nutrition, housing, jobs, childcare, education, safe neighborhoods. You know, what you and I have always called basic needs. We all know that if you meet a family's basic human needs, then they are more likely to have better health outcomes. They're also more likely to have better mental health outcomes, better education outcomes, better job outcomes, better life outcomes. We also know that there are challenges that prevent many families from meeting their needs, from realizing their potential. In human services, we work to provide an array of public and private benefits and services to meet those needs. Healthcare, including health systems, managed care organizations, and the New York State Department of Health, jumped on the social determinant of health bandwagon full force, which is a positive step to recognize that access to a doctor is not the deciding factor on people's health outcomes. Yet, the message to the human services industry has been that we need to show our value. That if we simply do our jobs well, people will have better health outcomes. And that is just not true. If we are not all sharing data, if we don't have a platform that allows us to leverage resources and literally see our neighbors who are living in the shadows, who are living in fear, who are living with a vicious stigma of mental illness preventing access to care, then we can't. And we can't meet need alone. We have to do it together. This isn't a radical proposition. This is common sense, and funding needs to flow in order to ensure that every partner meeting need is able to do so. So there is no unified, cohesive health and human services system on Long Island. Providers may partner somewhat in sending referrals to sister agencies and maybe even sharing office space here or there. But there is no client-centric system tracking families through the health and human services system, ensuring that all of their needs are met. Services are for the most part provided piecemeal between counties, towns, schools, health centers, and agencies. Sometimes families in need aren't even lucky enough to find a psychologist or a doctor. So often, a family's success in meeting their needs is determined by the person who answers the call at the other end of a referral and how motivated they are to navigate the maze of services. Not only do individuals and families fall through the cracks when their needs are often not met, families can be traumatized by the very human service system or lack of system that is trying so hard to serve them. Does that sound familiar? It's one thing when individuals have hate, but when systems do, when institutional racism and division impacts human outcomes, you have circumstances that we have today on Long Island. And let's be real, the current lack of a system is actually a system itself perpetuating inequity. The current experience of the mom of 3 boys that I've been helping this week, whose home is so full of black mold that her children are endlessly sick, and yet finding housing that meets their needs is so challenging. She is traumatized. She is traumatized by the lack of coordination that has befallen her family in their time of need. And that is why, as CEO of a very busy organization that does not even work with housing access, I've dived right in. Because how can I know any one of our neighbors is suffering this way and not try to untangle that web, not try to untangle that maze? And let me just be clear, with all of my resources, it's hard as can be. And I have yet to successfully help them navigate their needs because there is no system. When families have to travel by bus to community for different services, or when families have to provide the same intake information over and over again, or when families need to follow up on 3 or 4 different referral appointments, it can be completely overwhelming and even harmful to them. It is time to change this. And I know that we have the right people in the room today. We have thought leaders and providers, and together we can strategize and plan for improved systems that use technology and innovation to break down barriers, improve access, and create equitable outcomes for Long Islanders. Because while I firmly believe that Long Island needs to be desegregated, we can't wait. And lack of coordination around services impacts every community on Long Island. I've been asked recently to host roundtables in towns because of increases in suicides in some of our school districts. Each one of these conversations is about coordination, about the desperate need to coordinate services, and without an infrastructure, we are failing Long Island's most precious children. So we are here today to discuss health equity. Many of you, the collective in this room, have been working tirelessly to build a health equity movement on Long Island. Our communities are not just losing hope, they're losing their humanity, and therein their lives. We have a responsibility to reach into the shadows and bring problems that are on the fringe into the light for solution building. We have a responsibility to dare greatly. If a community's potential on Long Island is limited, yours and mine is too. If people are unable to access basic health care for any reason, if people are unable to access needed treatment for mental health, who suffers? Individuals and families, yes, but also schools and entire communities. A little over 3,500 Long Islanders are in New York State jails or prisons on any given day. And there are about 25,000 people being held in jails across our state. I hear a lot of talk about at-risk youth. We are looking for programming for at-risk youth. We want to help at-risk youth. We spent all this time addressing at-risk youth in one way or another. But how dare we label our children in such a derogatory way when the truth is that these children are filled with promise. What is really at risk is our infrastructure, our institutions, and our ability to respond, and perhaps our moral compass. When somebody reaches the jail, they have been failed time and time again by systems that don't see them. Could you imagine not being seen? Not being human? They've been failed by our schools, by families, by services, by institutions that have labeled them as at risk and failed to invest in them. And how could they not be failed when there is no system to know them, to see them, to serve them? There's a concept that I used to teach early childhood teachers, that no response is an affirmation. If you are confronted with someone saying something that's not okay and you don't address it, you are affirming it. Wow. We continue to affirm dehumanization as a state by not having infrastructure and making a choice to be blind. As espoused by well-known author Brené Brown, I think daring greatly requires us to be vulnerable. It is why, in a room full of people who work partly for health systems and the state, I am boldly saying that we have to be honest about the role that we each play. There needs to be state-mandated requirements of managed care organizations that ensures true mental health parity, improves network adequacy, and requires partnership with a coalition of nonprofits to meet these social determinants of health, again, what you and I call basic needs. They have a dramatic impact on health, social, and educational outcomes. In New York, unlike the rest of the country, Medicaid reform and redesign put all their financial investment into healthcare systems rather than community, rather than health and human services. Our counties, our biggest providers of social services, they were left out. Cost reduction of healthcare would be radically achieved if we invested in those basic needs that keep people well. Instead, we live in a state that, while progressive in many ways, has given managed care organizations far too much power. And it is access to critical mental health care that can make a difference for so many beautiful people, victims of trauma, who are spending their nights, who are spending their tonight in our jails. The state invested millions of dollars statewide to plan for a changed system. We now need to be able to implement an infrastructure because, for crying out loud, we're worth it. We are living in a time in which the assault on health and human services at the federal level is constant, where the people we serve are being villainized and likened with infectious disease or violent gangs. New York can lead. New York can lead on what it means to put people first. Here on Long Island, we are America's first suburb. And while deeply flawed in its inception, I will always believe that we represent a dream and a hope and can realize our potential if we build the infrastructure that you will hear about shortly from our keynote. I ask you to be vulnerable today. I ask you to think, to listen, and to be catalyzed to action. I ask you, on behalf of Long Island's most extraordinary lives of such priceless fighting each and every day towards a resilient future, to join me today in daring greatly. Thank you. Please join me in welcoming Health and Welfare Council of Long Island's wonderful board member and the Health Equity of Alliance of Long Island's steering committee member, Colleen Merlot.
I always find it challenging to speak after Rebecca, and it's not because I have to adjust the microphone. It's because it's really challenging to match her inspiration and poignant words. So thank you, Rebecca. So this conference comes from the work of the Health Equity Alliance of Long Island, a coalition of over 80 not-for-profits that represent a diverse group of agencies. We are diverse in size, we are diverse in the region representation, and we are diverse in our scope of services. We truly represent the fabric of Long Island. This conference is also the result of very candid and robust conversations that focused on building upon successful practices around system engagement and coordinated care. The coalition formed as a result of a grant from DSRIP, or New York State Medicaid Transformation, with the goal to reduce avoidable hospitalizations and save money through value-based payment. Through the tremendous leadership of the Health and Welfare Council, Healy used this opportunity to create so much more, and I'm so grateful that that's the direction we went in. The work has focused on client care that addresses health equity, cross-sector integration, and system development. There are many people, myself included, who have been disappointed in the design and implementation of the Medicaid transformation because it has lacked a focus on health equity. And as Rebecca so clearly illustrated, on Long Island, we cannot make impactful change if we don't recognize and address the disparities between living in one zip code versus another. Medicaid transformation has also lacked leadership around building the system and infrastructure of not-for-profit organizations and local government who partner together to provide critical human services to our communities. What the state defines as social determinants of health, this is what we've been doing for decades. Excuse me. The services that meet families' basic needs, that's what we do. And that's what improves health outcomes. This is not new, we know this. And while the resources have gone to healthcare providers, not-for-profit organizations are being told to develop business propositions to show their value to health systems and managed care organizations, with the hope that we might be included in the future. This has created a dynamic where organizations who serve our vulnerable communities, communities of color, communities of low income, are in a position where the lack of power and influence to adequately serve the communities in this new Medicaid dynamic. This is a moment in time to shift resources to systems, services, and communities. But it's up to us, every one of us in this room, and everyone else who you're going to speak to about this conference. We have to be the leaders in these efforts. We can't sit back and wait for the state or managed care organizations or health systems to tell us what service delivery is going to look like in the future. It's up to each and every one of us and the communities that we serve to lead and build systems that meet the diverse needs of Long Island. We have the experience in doing this work. We are the trusted members of the community we work with, and we have to ensure that we have a voice in transforming the system, or we will never have an equitable system of care. Today's summit is a kickoff of the next phase of Long Island state advocacy related to Medicaid transformation to ensure that healthcare and resources are about better outcomes for families and communities. It's about putting resources into services that improve economic stability, mental health, nutritional security, education, childcare, and safety, the basic human needs of families. It's about putting resources into communities that improve housing, schools, businesses, transportation, and jobs in communities. It's about creating systems and technological infrastructure needed to provide services that put the client at the center of the service delivery model, not the health system, not the managed care organization, not government, and not the not-for-profits. It's about the people we serve. The family is at the center, and we, the health and human service providers, are working together to serve their needs through a client-focused system. Together, we are stronger, and we need every voice in this room. There is an opportunity, and we have this opportunity now. As much as today is a culmination of our work, it's only a culmination of our work thus far. Please, if you've been engaged, stay engaged. And if you haven't, make sure you get engaged. And now I'd like to shift because I get sandwiched between two fabulous speakers today. I get to introduce our keynote speaker, Bill York. So, Bill is the Executive Rights Principal of 211 San Diego, one of the most successful 211 providers in the nation. And I had the opportunity to meet Bill over dinner last night, and I know that we're in for such a treat because he has a wealth of knowledge and passion. So we are in for a wonderful treat this morning. Under Bill's leadership and vision, 211 San Diego built and launched the region's first ever community information exchange to bridge health and social services to address health outcome, equity, and quality of life through a collaborative and multidimensional platform that provides case planning and facilitated connection to services to providers and clients, ongoing resource navigation, data, and outcomes. Sounds like what we need here, doesn't it? We are so excited to have him with us today. Please help me welcome Bill.
Good morning. It's great to be here. I just need a second I'm multitasking. So good morning. It is great to be here. It's great to be back on the East Coast. I'm from New England, so it's fun to hear all the accents and to see the green. And green San Diego is beautiful, but it's a little brown. So it's of course, so it's just nice to be here. And to Colleen's point, it was spending some time with everybody, Rebecca, Colleen, Emily, Nancy, Nat. It was interesting. I keep saying I feel very much at home with my team and the passion. And whether we're advocates or we're activists at this point of moving toward this system change happening. So it's an honor to be here. Hopefully I'll take you through the story of San Diego a little bit. I'm big on strength finders, and my number one is context. So giving you a little bit of where we came from and how this all came about is kind of important to our story. So again, New York, I've been with San Diego 211 for 12 years. Interesting journey there. But oftentimes when we say 211, that people will say they have ideas of what 211 looks like. There are 248 211s across the country, 50% of those being United Ways. And if you've seen one 211, you've seen one 211. So some are very, information referral services. Some have moved to coordinated care, specialty programs, enrollment, eligibility, depending on the support and the support of whether their county, their leadership, their region, their state, and actually sort of their creative business model, so providing services. So we took a journey years ago saying what we were doing wasn't working. And I think an important piece to know is a lot of 211s, in the 211 world, and even in the CIE world, we were often known as activists or heretics in moving to a more person-centered record. Even many 211s use call-based, so each call is original, and there's no tracking of that client. There's nothing of their previous experiences or referrals. And around 9 years ago, we had some national data that said that 50% to 55% of the work we were doing across the country was not resulting in someone receiving services. So at a national conference, when we were speaking at a keynote, it was, we kind of called, that the industry to, this isn't working, that, we needed to have some technology, we needed to have our own, be able to track our clients and their needs, their outcomes, over a period of time. That led us on the CIE journey. So hopefully I can walk you through some of that. Again, and kind of working both systems. Every community thinks they're unique. California definitely thinks that they're unique. We change the names of everything, right? So Medicaid is Medi-Cal, TANF is CalWorks, our SNAP is CalFresh. It goes on and on and on. We're special. But we're not that special, right? So everybody is unique, and then everybody has similarities. But to tell you a little bit about San Diego, we are, one of the 5th largest counties in the United States. I know I heard last night that you have many more municipalities than we do. I want to say over 100. So we have 18, and we have trouble juggling all of those and all of the things that fall within those. 18 tribal nations, 42 school districts. I think you're 124. And then we're very diverse. We're a border community. We go, from Arizona. We actually do the county right next to us at Hero as well. So up to Orange County, and then we have the busiest border. We have a huge refugee resettlement site in California. And again, we have a large military presence, and it's even growing more with the move to the West Coast. We have 2 aircraft carriers with 32 bases, with 120,000 active duty, 150,000 dependents, and 254,000 veterans that live in San Diego. So there's some interesting pieces of San Diego, and again, that do have a piece of uniqueness, but I think everybody has that uniqueness, and I learned that from Rebecca and Emily and Corinne last night. So again, a little about 211, our purpose was to be a 211, right? To actually make positive, lasting impacts on people's lives and drive meaningful change throughout our communities. We changed from a simple INR model many years ago when we saw it wasn't working. One of the great things about San Diego and California, well, it's great for us, is that there's 58 counties. The counties do have strong leadership roles. So in the county of San Diego, our county's health and human services with over a $6 billion budget also contracts out to 997 community-based organizations delivering services. So a great amount of support to improve coordinating services and for us to be the designated one-stop shop kind of changed the way we were creating our services. And we're also, our mission is to serve and, as the nexus in bringing community organizations together. That's not always naturally a 211's role. Maybe a United Way, and obviously if you peer play as a convener, but we weren't naturally in that role, and we have become a nexus of coordinating our agencies, programs, and services. To give you an example, there are over 1,200 nonprofits offering 6,000 services in San Diego. Now, 211 will refer you to any of those agencies, programs, and services. Those are not all the people involved in our CIE, which is a much more curated network of connectivity. Now, we'd love to have more as we're looking at who we continue to add to the benefit of what they do and then the multi-sector work. But we're not trying to harness those 1,200 or 6,000 at the level of our CIE. But we do refer to all of them. So our base 211 is intact. Over the years, we are 24/7 free dialing code. Probably the biggest funnel into community services. So if you think that we have over 400,000 people calling us a year out of a $3.3 million population. So we have a lot of contacts, a lot of people calling in looking for resources. So we're creating an incredible amount of records around those clients. Again, what's happening to them and whether they're receiving those services or not. We are the designated access to community and disaster services. We have a large role as a 211. I don't know, you probably see that California's on fire a lot. We have no water. We steal it from everywhere else. And then we tailor programs. This is something different. In seeing gaps in services, whether it's veterans, whether our CalFresh numbers were one of the lowest in the country 8 years ago. California was, and they were likely eligible, there was no access, there was a stigma, and there was a cultural issue at the county's levels of access into SNAP. So we have an enrollment center around Medi-Cal, Medicaid, CalFresh, and actually even covered California, which is a marketplace. So as well as we've crafted a health navigation program that stemmed out of the Affordable Care Act of doing much more intimate work with clients, much longer engagement with them around their health needs. That's also led to our connection to the healthcare system, readmissions, work, and so forth. So the community information exchange, it really was to foster collaboration across the network. I mentioned all those agencies. There is no single agency that actually is connected by technology to another agency unless it's through our technology at this point. And you see that every agency, according to their size and scale and budget and programs, that they have some more sophisticated system than others. So we have some amazing, impactful senior organizations using Excel sheets. We have others that are using homegrown, access systems. We have others that are using social solutions, a CRM that they purchased to track outcomes. And then, so we still see binders going around in the organization as well. So one of the things is to actually, we have become that cross-sector of where can there be a one source of a golden record of what's necessary to make interventions, to get more information, to drive change, again, whether it's EMS visits, and I'll talk a little bit more of that. So we're also moving to person-centered as a community. So when I talk about CIE, we'll talk about technology, but it's actually a movement around systems change. It's having these agencies, these trust network partners work together in the community care planning. Our CIE Trust Network meets not just about the technology needs, it talks about how do we do this, because many times we're in their programs and services looking at the workflow. How do they integrate more information into the systems they're already doing? And our goal is to improve health and wellness for individuals in our populations. I want to make sure that I share with you anything we've done. I get to come out and speak about CIE and about 211, but nothing we have done has not been in partnership with, whether that's our county, with other providers, healthcare providers, and a great amount of support. So I get to be a front man of all of this, plus an amazing staff that looks like it mirrors the staff here in Long Island, of passionate people that want to make change. So that is really our goal. Just again, a little bit of history. The United Ways began, in the 20s, and free confidential information lines really stemmed up in 1974. For us, the big catalyst was we were kind of kicked to the curb from United Way in 2000. So we're in for line with San Diego. And our local United Way felt we were too many direct services in a cost bucket to them, actually. And so it left us to our own devices to actually become independent and become strong. Also, our services were sort of weak. If you look at those and hear those numbers about the results, we needed a makeover. We needed to look at the quality of services and then kind of tip INR on its head.
We did that over a period of years and received the dialing code in 2005. The San Diego fires put us on the map as well, and making awareness to 211. At that point is when we realized that we needed to change our model that I spoke about earlier to a more person-centered record, building those programs and services, better quality, again, client-based, quality assurance programs. Interesting enough, I had funders, partners telling me 10 years ago, what does it matter, what does it matter how good a call is or the referral is as long as you answer the call timely? Why does it matter that you can measure the quality of that interaction or how the client feels about it? We don't want to pay for that, we just want you to answer the call. So really interesting things happened in changing our model in support of the quality of services and outcomes. In 2011, Alliance Healthcare Foundation, which is a foundation which was created to serve the underserved, specifically around the Medi-Cal and Medicaid population in both Imperial and San Diego County, and they have an innovation grant of $1 million that we applied for as a community, about 32 organizations, the Homeless Information System, Regional Task Force, the County of San Diego, healthcare organizations came together to put in a grant, and it was awarded by Alliance Healthcare. We were the fiscal sponsor of that, the CIE, and the term CIE, and the thought process that was born. And you can see that's 8 years ago. And we are still building, but we have reached a certain point where a tipping point. In 2014, CIA launched a pilot cohort, with client demographics. We also expanded our health navigation department, which plays a great role into this. We had a second cohort in 2015 around seniors and the aging population. We added another veterans. Again, we have a very sophisticated prevention intervention veterans program funded by Mental Health Service Act dollars. We laid another platform over for veterans coordination called Vest United, built on Unite Us. And then we launched in 2017, our 100% of our agency around the client-centered services again. So every client has the opportunity to client record. Every client has an opportunity to opt into the CIE Trust Network. At this point, we have over 225,000 unique individuals in our system, with over 120,000 that have consented into a larger sharing of their information and data across the 68, as of this morning, network trust partners. So I will go over who they are. And then there was a complete merger of the CIE 211 into, again, the community said this, we kind of resided outside of us for a while, came back in and said this should be one thing. Your vision and your mission matches with CIE. It should be moved in as an agency and program of 211. And so we've continued to change our technology, build our technology on a new platform we just launched over a year and a half ago. I'll show you some technical slides on that a little later. But one of the things, again, this is important, when I talked about the support and I talked about our region, is that San Diego County itself has been a fairly conservative place over the years. I'm not sure if that's moving on its own, if I'm doing that. But the Board of Supervisors, again, a strong voice for our community, in 2010 came out with a 10-year plan called Live Well San Diego. And it had 3 tenets of building better health, which inside of building better health was building a better service delivery system. I mentioned those 900 contracts with community providers. Part of those was integrating their services, building a better network, and improving services for wellness. So the 3 tenets were building better health, living safely, and thriving. And each one of these has a whole host of things that fall under them. So it wasn't just about wellness. It was about safe walking communities. It was about food deserts. It was about what is the county doing? The county has 17 individual different pieces of technology that do not connect to themselves. They do not know who their customers are, from one to another. And so this really set it on a path that we completely adopted. We looked at that and we became one of the first Live Well partners into that, believing that system change worked. So having that vision led by them and with our Board of Supervisors, we really bought into this Live Well concept. And we bought into the idea of moving to people into thriving and self-sufficiency. So the whole concept, again, it was to begin with one family, and one person, one family, and talking about the greater needs. We had been screening our clients for multiple needs for a long time. Very few of our clients come in with one thing and we can solve it. So, housing, financial assistance, transportation, healthcare were the first big pieces. See, this is some type of timer. Albeit, so this is sort of the concept of live well. The county decided actually to create an investment in connecting their systems. So again, a big catalyst was on the county side of this, and if you think that the county sees that they represent 3.3 million people, that they have a responsibility to know if someone's going into probation or eligibility operations or foster care or child welfare services or child protective services. It should be a whole person, it should be a person-centered approach, knowing that that customer is being served by somebody else. So they built that system, and we have been working in it for several years. It's on a timer. So the Connect Well Hub, again, links at this time 11 systems into a massive technology called Connect Well. And as of Monday at noon, the firewall is lifted with all the securities and protocols that it now connects to our CIE. The data is actually exchanged around program services and enrollment and referrals, so we can actually know if this person is known to the county, around their SNAP benefits, their Medi-Cal benefits, their TANF. So our partners that are working with these families can see that there is county information as well as this CIE. So it is a great partnership, and Connect Well has been a leader in that for the last 8 years. We also have, a healthy HIE called San Diego Health Connect. Again, they have linked most of our healthcare systems in private independent physicians into a shared system called HIE, and that has all, again, labs, hospitals, all the pieces of an HIE. I know you have strong HIE here in New York. As I understand them, there's over 88 HIEs in the country, according to SHEEP. And then, so where we came together years ago was saying, well, there's a trifecta. Now, we call this the iron triangle, which I don't know where that reference came from. We've called it a tricycle. We've called it, so we've called it a lot of things, but we did come together with these 3 initiatives. So 2-in-1, Connect Well, the Community Information Exchange, and the Health Exchange, to really come with a person-centered community. That's public benefits, that's government, that's the social services, us representing those social service provider programs that had no uniform record, and then Connect Well. And 2-on-1, they didn't have no in. I will tell you, I get to travel, and we know there are over 400 communities talking about light CIE activity, whether they call it that or not. But we know that there are 400 Robert Johnson has put out literature. There's over 400 communities talking about this. So 2-on-1, we have been lucky enough to be put at that place in San Diego. We know that's not necessarily the model everywhere, because there is a convener or there is a backbone organization already. So we're lucky enough that we've been able to be put into that place and play that role in San Diego County. So, we really wanted to, I think, as we mature, drive interoperability. That is the question. I think it was mentioned in many of the talks this morning. People are prepared to move their platforms, and it's very hard to work in multiple platforms. At one agency, they're using 36 different pieces of software for transportation, food, for housing, whatever that designated funding it comes from. So, making sure that it's interoperable to their systems and the data can exchange through some type of interface is important. It's important also for identity management. So something that we're still trying to overcome, and I mentioned all those records, patient identification, client information. We've had a great deal of discussions around consent management when someone consents to share across not only nonprofits, right? So what are you sharing? Why are you sharing? Data use agreements, but also from covered entities to non-covered entities, clinical to community around authorization. So it was great that all of us worked together in a great, task force that became CIE in the county around these notifications and alerts in the system. Data quality. Not every CBO and not everybody, every agency has the same data quality standards of what you put in. Is what you put in, is what you get out. So, part of our work groups is around data quality in working with our CIE network. Data provenance, who's putting the information in and how can you see it and who changes it. And making sure the PAI conversation, I think that truly was a rabbit hole that we spent many, many years discussing and continue to discuss. It's a living, breathing. And then public health to primary care. That's a big piece that is trying to be solved. I think healthcare is trying to solve that as well. Making sure that we keep them on their toes of that the community also needs to be part of those conversations and also funded. And then proper presentation of the summary of information, plus the closed loop referrals. It really, if you don't know if someone's moving across the system and you don't know they're receiving the help or not receiving help, there's valuable data of why they're not eligible or they can't access it, whether it's transportation or there's a piece of eligibility you didn't know or they're a dollar over income, so not receiving it, and then what do we do with that information? I share this, I don't know, has anybody read this book, American Healthcare Paradox? I wish I had brought copies for everybody. So a few years ago, we carried this around as our Bible at 211 and CIE. An incredible book that was written by Elizabeth Bradley and Lauren Taylor. Lauren just spoke as a keynoter at our summit, really wanting to shake up the healthcare delivery system, really want to shake up the payment models of getting it out to the CBOs. And it talks about, you can see this quote here, it's one I think the most important, is that inadequate attention to the investment on services that address the broader determinants of health is unnamed culprit behind the United States spends so much on healthcare, but continues to lag behind health outcomes. So 20 of the largest nations that are investing less in their healthcare are investing more in their social services and have better outcomes. And what I love about this book is, again, there's many studies, there's many things to learn, there's lots of things that we use to drive our conversations, and I wish I brought my book. It's posted, it's ripped, and it's written on, but it was something that we bought for our whole team because it really speaks to what's happening here. And Elizabeth and Lauren will be coming up with another book, but I think it really goes to the investments in larger systems, economic, environmental, and social support, produce health and support individuals, much for well-being. Right? That says everything that we're talking about right there. So if you get a chance to read it. Another thing that has come up, since we've been working on it is the state of the field. So, 20 years ago, even 10 years ago, I think public awareness, I just heard last night that New York created the Bureau of Social Determinants of Health. There are variations on that as well, right? So there are several different crosswalks of what those social determinants are. There's some similarities, but some differ. But certainly the public awareness, the healthcare awareness, and the social services awareness has come to, again, another tipping point. We're all talking about them. We're all talking about how to measure them. How do you measure them? So, and so there's a great deal. So, and that is definitely front and center here. Person-centered. Interesting, because if you ask someone person-centered in most communities, you will probably get 20 different answers. So what does a person-centered record, what does person-centered care look like? And so we've tried to hone in what that means for us. So not only on the 211 side, not only on county, but all of this. What does that mean with more information to be person-centered around health and, again, social service referrals? Technology. There are more pieces of technology for referrals, bidirectional referrals. We don't see a lot of the interconnected multiple data source technologies that need to be integrated. We haven't seen one out-of-the-box system that can be purchased. But certainly there's probably, there's the old INR software systems that are, have certainly started to move to a greater competence. And then there are new systems with bidirectional referrals popping up that are selling to healthcare, saying, we can give you referrals to the community. So there is a proliferation of technology, some of those with the best intentions and some of those with venture capitalists looking to work with, to sell to their shareholders. So cross-sector collaboration. I'm not sure if you've heard of Stewards of Change, doing great work across the country around changing healthcare, the healthcare social dynamic. They have a group called the National Interoperability Collaborative with quite a bit of information on what these public sectors, public health, eligibility operations, healthcare, social services, disaster services. There's a great deal of what that cross-sector collaboration looks like, and it's happening. It's happening in maybe the macro levels of what a CIE is, where there's no single cohort anymore. But there's also one around the opioids and legal and law enforcement and the judicial system that's happening as well in cross-sector. And then the evolving funding. I'm sure anybody that's a nonprofit, we've seen the funding and philanthropy change. There's great movement to supporting this coordinated care and data sharing interoperability in some foundations. And then there's some that, that I would say that we've all felt, not new, but certainly GoFundMe, and the other ways that people receive philanthropy has changed. So good and bad, there's a whole different movement around. But there is evolving funding for this kind of movement. That's what we like to call it, at least in San Diego, that supports the work. And then research and policy and advocacy. So we have tried to find our way in our home, and I was sharing with Rebecca, Emily, and Colleen last night, where we belong in this kind of new world, right? HIEs have some standards and directives that they have, and even software, technology standards. That some people say there are no social service standards around data exchanges. Some say there's no mutual consent, and so we've moved quite a bit with several projects around research, and there's a lot of, whether it's Siren out of San Francisco, other organizations across, Robert Wood Johnson's Data Across Sectors for Health, and with some policy and advocacy looking for change. So really the state of the field has also changed in just the short time that we've been working on this. I think, everybody's probably seen this slide at this point. It's used a lot, but I think it's an important one. If you look at that only 20% of your health comes from clinical care. So I think we all realize that. And then I think a lot of people are trying to conquer the health behaviors of, tobacco use, diet, exercise, alcohol use. And then as you move up, it's that physical environment, the housing, you mentioned zip code. And if you look together, it's actually the socioeconomic factors, right? Access to those basic needs. So whether it's family support, counseling, alcohol, substance abuse, income, housing, all of those things that really makes up a person's wellness. So we really use this is that this is again, it's as where this is noted from. So we have looked at it as, our person-centered care, that we're looking at all sectors to integrate. So whether it's housing, primary care, health management, nutrition, again, utilities, again, anything that has to do with supportive housing, education, legal is a huge piece of this with the veterans community and others around public benefits. Even social connections, what people have access to is important, faith-based connections, and activities of daily living. This is what we look at as person-centered care. In San Diego, or I say in California, now I know everybody's aware of the 1115 Medicaid waiver, and the way that San Diego and California rolled that out is they rolled whole person care pilots out. The whole person care pilot, and this is something that we've seen more and more initiatives are bringing CIE because they see a value base. We're doing a lot of preventative things in homeless. If you think of HMIS systems, so you are homeless or entering a homeless program, you go into that. There's no upstream of what happened to you the 2 years before. We're trying to conquer that too, about all the interactions you're having, so we can have some prevention programs. So we have been designated as part of the whole person care pilot, which allows the county to holistically address the needs of Medi-Cal enrolled homeless and qualifying for mental and behavioral health conditions. And so we participated in that group. Again, it's been a big catalyst. It starts there's a different movement starting in 2020. But we probably have 20 initiatives now that are using CIE as the sole source around homeless, some DPP programs, specialized other, going back to cohorts around certain multicultural or hard-to-reach populations. I mentioned the proliferation in technology. That is really blown up. We hear of a new software that can do everything every day, and we have great sales pitches. So I think it's important to know what do they do. And so when I talk about what's in our CIE, it is not just bidirectional referral. So it's what goes into a CIE with multiple data sources. So I mentioned the cross-sector, a breakdown to the clinical to community referrals as well. Here's an important piece of what we consider the components of a CIE. So we actually have to have a curated, I mentioned 6,000 services, 1,200. That is not a curated partnership into CIE. Our 68 partners have BAAs, partnership agreements, data use agreements, and they're a curated trust network partner that have specific data roles, access, and permissions into the system of what they can see based on what their needs are. So that network of partners is important. So they're important for the bidirectional referrals. They're important for 38 of those 68 actually share data back in a push-pull to the system, again, for the record. We learned quickly that not every domain or sector speaks the same language. So an outcome over here, and an impact here, and a HUD requirement here, and healthcare here is not the same language. So we have had to really work with our network and our different sectors on having a shared language. So again, more than just the technology, that group coming together on a monthly and having a shared language is part of what we consider CIE as well. So, of course, our resource database is important to us. We take great pride on that being accurate and up to date, which is not just a listing. A list is a list is a list is a list. So, agency program services, eligibility has blown up, the difficult people accessing programs and services. In San Diego, if you don't have, an ID or even, something with your address on it, you're unlikely you're going to get a box of food. So eligibility has also changed over the last 12 years, so making sure that is a really robust of people, making sure people get to the right place first time. Of course, the technology integration and the platform and how we did that and how we built it a year ago and how we might build it 2 years ago has changed because of, again, proliferation of new technology and data sharing. I do have a slide for that. And then community care planning. I can't tell you how many stories in our journey that sent us on this path in 2011 of hearing a client that would talk to us for 15 minutes, hang up the phone, tell that story again, get sent again, and then hearing that now there are 5 agencies working on a Medicaid application for them. Agency B solved it on Tuesday. The other 4 are still working on it, and have resources. That story goes on every sector, on everything, because of that telling that story over a client doing their own care coordination. So inside of our CAE, knowing who was the past person of record, who was the last case manager, who was the last 211 individual that touched and gave a referral to that, and so the internal communication around that care coordination. And again, that's a great group that comes together and talks about what does this look like. And it's interesting to see the passion in that room around this is needed. By the way, years ago, when we talked about data sharing in this group, everybody was like, we can't do that. We can't do that. HIPAA, HIPAA, and it was a great reason to say no, And so I will say, because of the CEO and the executive buy-in at all levels, that we have passed that we very rarely hear that. People want to know that we've checked all those boxes, that our privacy security officer, that our controls are in place, and we have built that to the same level of healthcare's requirements. So again, not actually having requirements, that's what we decided to do. So they asked the questions, and I'm sure those will be some of the questions here too. But I think we have hit, again, another point where, it's not, should we or could we, it's, we need to do this. So for that campaign. So our partners, again, we are adding quickly. Again, now that we've reached this, we've reached a certain number of people in CIE, we've reached the value proposition of what that is. The sectors that we have in the healthcare sector, we have health plans, again, that are also funding and support, so they have access. We do have we have 7 healthcare that have managed Medi-Cal, Medicaid programs. So again, we have many, so Molina, Care First, we get St. Paul's Case, with healthcare. We have other ones joining, so we have Scripps and Kaiser Permanente are joining us this year. Hospitals, and we had Scripps, UC San Diego, and Sharp. Emergency medical services, so we have not completely conquered this for all of San Diego. We have cities that we can get EMS transport data, but not San Diego County as a whole. So large city, San Diego, and then San Marcos. This is really important because if you can see a transport, it's amazing to see what happens to a client either after transport or after a jail, some type of jail or law enforcement interaction. So our health services, again, we have large FQHC clinic systems in San Diego. They also have designated CIE for recent legislation called 1152, which is mandating hospitals to actually have a plan before they release homeless into the community. So most of the healthcare and health homes will be using CIE as their record for that kind of work. And then, of course, our health information exchange, remember I say the Health Connect. And then behavioral health, one of the ones we still continue to, I say, work hard on is our behavioral health information and sharing for the GCFR. What can be seen? Who can share it? What's the authorization? And then what's that chain of custody? And then, of course, public health of San Diego primarily. On our social sectors, we looked at, and this is the kind of the curated network that I talk about. We know our top needs, like many, and I haven't seen this vary too much from community to community, that housing, right? Affordable housing, certainly homeless and emergency housing, so availability of beds, sort of multi-service agencies that do many things, right? So we have two large mega agencies that have 100 different programs, from senior on the RIDE programs to food banking. Human development and aging, again, we're looking at to be livable community, and so we're working a lot with our aging and aging independent services. Legal, our legal aid, again, is a strong partner seeing the population they serve, is now in CIE. And then employment. So this is our workforce partnership, is a conglomeration of DOL dollars, large around opportunity youth, and they directly share into our CIE. Anybody that joins their program has now become a CIE individual. And then government, we have the Connect Well, the City of Chula Vista, the City of and the City of Vista. We have plans for the rest of the cities again, but it's all around what they're going to use that data for. Each one has a data use. It's meant to be about their citizens, about their clients receiving services, not used for any other purposes. One of the things that we built into, and I was speaking last night that I don't know if a lot of people know, is that as we're moving along and talking about not only a CIE, but how does someone quickly view this? If you're not necessarily a social service provider, if you're a healthcare provider, and you want to view into that as client has more information, we need to make that easily, and I don't know many, I'm older than a lot of people around, but that 3 licks to the center of the lollipop of that owl years ago, right? So we can't have people go fumbling around, taking too much fine, find out that the food is secure, and that's not just about one meal, that's about access to it, that's about regular SNAP participation, that's about transportation, that goes back to the core problem of why they're food insecure. So what we've created is actually a risk rating scale around these 14 domains that discuss the immediacy, knowledge, and utilization of various support, and actually plots. So if you think about all the data coming in, so it's not like we do the assessments, we can do the assessments, other agencies can add to that are allowed to because of data quality, as well as if something comes in from HMIS, or the OASIS food bank system, or EMS, that plot changes. If someone starts to receive permanent supportive housing or housing, they change on that risk rating scale. So it's a quick view in to see where somebody is around these domains, and it's a quick access to be able to do something about it. When we've talked to providers, they're like, I don't have time to figure out what referral is. I need to know if they're at risk and what I can do with it. Click, click, click. So it's also, we see that our network is using this a great deal to see. This is the longitudinal part. There was no record that took someone for our community and saw our complete history. Now, as a small example, we were always working in utility assistance, and we could see people getting disconnected or they couldn't pay their bill. We could see patterns on 1 call, 2 call, getting assistance, not getting assistance, to shut-offs, to in the dark, to guess what was happening next. 3-day notices to quit, eviction, and so paths to homelessness is something as simple as utility assistance over a period of years. So having a longitudinal record that shows changes over time is important to our community. So it's not it actually has a history. And as we have more time behind us, we can actually see and do more predictive analytics. Again, our resource database, we're quite proud of it. It's referral, bi-directional. We have a whole staff that curates this as well. We do follow AIR standards because we're 2-in-1 and an INR and part of the Alliance Information Referral Systems. So there is a great process for making sure that's up to date. We kind of put that on the next level up there of that connection to our agencies, programs, and services. So the technology platform, this is what I was just kind of speaking of around technology proliferation. So when we were looking at, we want multiple data sources. We knew that the EMS transport, jail data, HMIS, which is a HUD-required system for homeless management, there is all slightly different, all different models of who runs that. Some of it has accurate rate information, some of them do not. In order to link to that, we wanted different information to flow. We also needed to make sure that Bill York is William York, is Billy York, or maybe Huckleberry Finn. And so we needed something to see that it would be translated and matched to a certain percentage that could then be populated into the CIE. So we used a tool. Again, there were many out there. It's what we chose at the time. Our technology that we went through a very careful and open procurement process is built on Salesforce. But there are other technologies out there, so we're actually technology agnostic. And even Salesforce now has an integration of middleware just since we built ours. So that's what gives us the linkages to agencies, programs, other data sources. Interesting enough, we talked a lot about meeting agencies where they are. Excel sheets, CSV files, PDFs, APIs. This also allows us to consume anything as long as it's put in the right format. So we can upload an Excel sheet, a PDF, all that integrates into the right. As long as we map it out right the first time, it all goes through that exchange transaction layer and middleware. It's also where identity management happens. So this is really complicated. I don't know if we want to go into all the workflows that we have here. It gets a little sophisticated about how we run our operations. We are very much at the center as the backbone of this technology. We are very much the person that sees probably the most records. Then just the sheer numbers that we're using, we use that to do person-centered and better referrals. That is growing by our network partners, and you can see that the workflow of the CIE is very mapped out, and this is worked on a regular basis to our CIE network team. From the client profile, the referral management. Again, we're big on making sure what happens with the outcome if they're receiving services. Now you can imagine, I think you already know this, they might access to the agency and they might start to be served that doesn't mean they receive services. So we track those workflows. It's an ever-changing process as more partners come on and we get into their workflows. You might see this vary by agency. Again, our big piece is, and this is what we're, trying to harness working with our agencies and our trust network is getting the referral closed with outcomes of what happened. So, did it work? And did it not work? Because that's actually valuable as well. When I was early getting into social services, we would talk about, they fell through the safety net, the cracks, and they disappeared, and they're never to be seen again. They're out there somewhere. Well, it's interesting to now have all these thousands of records of watching people spin and to just churn in not receiving services. Now know who they are, why they're churning, what they're eligible for, and what are we going to do about it. So, we now have an ongoing active, hot list of people that are not receiving services for whatever those reasons are. So even that data of where they're not getting successful, we actually are seeing what we can do to do something about that as advocates, as voices, as activists, saying there's a problem here. There's a food desert. There is no place to buy healthy food. We're seeing this in certain zip codes. So even that data is valuable. Our CIE shared, how am I doing on time? I have no concept. Okay. Our shared CIE record, this is really where the rubber meets the road. So, and we're proud of it. So, our client record has the demographic and obviously important information about the client. It's also where that provenance is. You can imagine agency A might have different information than agency B, telephone numbers change, so you can see what the most up-to-date, most current, and most accurate is. You can also see all of what's happened before. So we'd actually have cases where that was helpful because the main point of contact that was in there was not the one that was needed, and a healthcare organization was able to contact them in an emergency situation. So it has the basic demographics. The domains, those are the 14 domains where we crosswalked across several different national agencies of what domains they're using, and then map that to our providers around what those assessments look like. Our care team managers, again, working with clients across agencies and contact information, all the referrals to programs and programs enrollment, agencies, programs, and connections to services. This new win with the county, which has been planned for years, we now will be able to have county information to select on mostly public benefit programs. If you know that the client is already known to the county for SNAP, CalFresh, you already know that they're receiving Medi-Cal or now you know that their Medi-Cal or Medicaid needs to be renewed, or some action needs to be taken. They are sitting in front of you. You can proactively, because I don't know here, but during Medicaid expansion, we had 20% people falling off of Medicaid because they didn't supply their documents. And so 65 days out, they were starting to be cut off. So having information around their CalFresh SNAP benefits, even their amounts, that the agency doesn't have to go down those services. And so the enrollment of those services, again, in CIE is important. Again, it's for the caseworkers in the agency. The alerts and notification if you're working with a client. So you want to know if they're having interaction with us or with law enforcement or EMS, is that you set those parameters. So Bill York, I just got a house last month, and now he's calling 211 for utility assistance and rental assistance. What happened? Right, free indicator. I want an alert on that. I just got the house. So our alerts and notification, their jails, and any ability for any of the care teams to kind of set up those notifications is really where we're seeing somebody needs to take an action in those alerts. And then the feed, the ability to communicate with each other. This is the community care planning. I'm working with Bill on these 3 things. Everybody has their expertise. A lot of places say, well, I've got you, I'll try to do this, but I'm not an expert on Medicaid application. I'm not an expert on the SNAP application. I really don't know what I need to do to get you medical transportation. This allows us to have that communication around sort of really multiple people working on the same case, the care coordination. This is what our record looks like. Again, it does, you have to click through a few places, but we have, and it does, we have a great deal. You can see our domains, you can see the quick up to the right, the different risk indicators and where they are unstable. If you were to click into those, you can see what are the assessments that go into the show those indicators. And they move and show progress over time, or they go back up. Again, household, connected household, family members are all part of this. Military status, enrollment, retired, programs, basically, again, we have looked at each one of these fields and what's valuable for our partners and what brings value to them. So, and then looking at, what do we see the benefits of CIE? There's obviously been great benefit already in coordination and outcomes for our partners. Healthcare is obviously interested in connecting to social determinants. Primarily it seems around housing and transportation, but there's some major moves across the country to connect. It's really important that we, stay vigilant on what does that payment model look like. I've heard from some saying, well, they're already paid to do that work, but I get them a referral. I don't know where I need to be involved in some type of payment. Of course, we don't advocate for that, more work and more referrals. The benefits really at individual and family is that we're seeing the larger picture across government, healthcare, and CBOs in San Diego is they're able to have a better view into that family. Obviously, at the agency level, agencies are now having a longitudinal record that did not exist in San Diego of a person and what's happening over time. So we estimate that we'll probably have over 250,000 people by the end of 2020. That are in there. We think that there's about 900,000 people receiving Medicaid or Medi-Cal in San Diego, so 1/3 of our population. So again, which we see as a population that we're serving. And then sort of that macro community part is really being able to report, advocate, what we're seeing, and what we're seeing in outcomes. And I think we have a great cohort of our CIE advisory, our county advisory, in being able to push this information out. So whether it's to create new programs or just be a voice for the underserved, or again back to where things are not necessarily moving forward. So it does have this, the individual micro, meso, macro effect that I think that we're definitely seeing. So a lot of people like to see this here, our early cohorts, and we're about to do another study. We were able to show that we reduced emergency room trips, from just people opting in. This was a very small early cohort. We saw the data in a third-party evaluation that we reduced the trips pre- and post-enrollment. Just being enrolled, that someone from one of the homeless providers could see that this person, and there was only 6 providers in there at the time, that we reduced those emergency visits a little bit. That was based on a project called Project 25. So clients with lookups. So that means that agencies going in, and by the way, about 2 years ago, it was about 5% of people were being found in here. Where 42% of lookups are now finding the client they're looking for that has additional information that they can make decisions on. So again, here, the average number of EMS trips pre-post enrollment. The lookups, back to lookups, they have fewer trips in post-enrollment. Again, if they're going in, this is early data, so we have much more on this now, that if people go in and use it, they can see that it's valuable information. So that's a big piece of the work we're doing now is around utilization and workflows, as I spoke about. So, and then the number of transports, in the 12 months before and after, you can see that, have declined as well. So we're going through another project of making sure we evaluate third party. We have several opportunities that's happening now. So I think this is interesting here is that, as we look at our patients' needs, and again, we're able to look at 201 patients versus comparison group. This is some work that we did with Sharp Hospital. They came to us to work with CIE as well as health navigation. They had a 30% readmission rate penalty. They decided to give us a group of patients. Their social workers took another group, so it was kind of controlled groups. We were able to bring that down to 9.6 between using CIE and using that we had a better idea of what services that were available. So we now have contracts and grants to both CIE and health navigation to work on the readmission. Now it's interesting because that was paid for sort of community benefit dollars from those hospitals at first. It was not operational dollars, so they didn't necessarily see it as paying us from the savings. They saw it as paying us from their foundations. So, but we have moved to say, this is part of your operations. This is part of you're taking, not having the fines and penalties and actually implementing, and that has moved with 3 of the hospitals. So, but those were sort of the early days of using CIE along with the health navigation. Finally, I know it's getting close to, so if we looked at sort of our outputs and outcomes and impacts, lookups count. Lookups, recorded lookups, and sharing the data, consents, and direct referrals are important. And one of the outcomes is that we're really moving to improve wellness, and the state of wellness. We want to change from domain-specific to the whole person care work, and then change interventions and interactions with people helping people. That's something we're documenting. What are you doing with it, Agency A? What are you doing it? What are your interventions? So, and then improvement on health indicators, advanced quality of life, and really we talked about health equities and address race, gender, and the cycle of poverty as well. So I have some resources here as well that, we have a toolkit that is pretty comprehensive that we put out last year. Again, we know that one model doesn't fit all. We've spent a great deal of time on legal, consent, privacy, security, technology, care coordination, care management, case management, social work. So, happy to share that as part of our mission. And we actually were funded also by the Howard Schultz Family Foundation to help proliferate at least this conversation across the country. So, it looks like I'm almost up, so I want to open it up to questions again. So. Sure. So, just, I know I touched a lot. I mean, we could talk like all day just on this, and because there's so many components, and so that's why on the resource list there's much more reading. You can download the toolkit. I know that we have some mentors of ours in the room with Northwell that Matt has worked with our team on going deeper levels. So, are there any questions on some of these components? I'd love to.
Hi, good morning. Excellent job that you did collaborating with so many different participants and stakeholders. My question regards EMS, because it's very clear that there's a key role there and a tremendous potential source of data, including what conditions from what communities you're taking to which hospitals, etc. In Nassau County alone, we have no centralized EMS in the sense that the hospital systems have their own. We have literally dozens and dozens of volunteer EMS. So my question for you is, what is the EMS structure in your county? Because I think it plays such a key role. And it is, if you do have so many dozens of independent volunteer EMS, how do you tie them all together in a program?
So it's interesting, we don't have dozens and dozens of independent volunteer. We have the largest is San Diego City, which we've conquered and does have has a process of where they get that information. It's a little different. You have to have an authorization for that client to be shared versus just I will never say it's a basic consent. So that has been conquered with San Diego is the largest city. Then we have San Marcos as well. The rest of them all fall into one piece of technology called water. that we're having a difficult time with the rest of the counties, the rest of the, where they're kept. We're in negotiations. It's like anything else about getting that data, how to get the data, how do we get it the most easily, how often can we get it, and we don't want to, it's really relevant to get it timely, right? So, and we're able to do that with San Diego. One of the big reasons is our chief medical officer and ER physician for San Diego County was also on the board and the steering committee of making CIE happen. So he was able to, he had EMT and he already had sort of a social work community, clinical community linkage from EMT. So he made that San Diego one, and now he's on our board of 201 CIE. And so he clearly is a great thinker on how to move this and get this data. We did venture down, again, that rabbit hole of what we needed to make sure the EMS data could be in there each one. So we're working on it, but it's not as many as yours. There are a few systems, and there's one major, if we could link to that, which our HIE does connect to, and so we're in negotiations now. Mike? Thank you.
I have a question with respect to referrals for all of the different services. On Long Island, we have 2 departments of social services, each of which manages emergency housing referrals. We have a homeless management information system. My agency does the coordination for permanent housing through the COC. We have a mental health housing entity that does referrals for mental health housing. And that's just the housing world. So in your system, does your entity manage all of those referrals and placements along with others, or are those housing ones feeding into you?
So we do not manage the placements. So we do referrals. And again, I can see that Long Island is it's complicated. So we specifically have been funded to have a housing navigation department by the city and county of San Diego. So we have a specific housing group that actually can do the variations. We can't do placements. That's what's interesting. Now, we're hoping, even with the emergency bed availability, we don't have, we're looking to be, to make sure we have that real time, but we do not do placements. It's done at the agency level. So in the HMIS, it's 55 different providers. We do have those other types of housing as well. So we can do the referrals. Again, some of them are in a network. Some of them are just cold referrals to those programs and services. But it is our goal. Our housing team that just expanded quite a bit really know our housing navigation and use CIE. It's another place where in this new contract, they are asking all of those providers that do placement to work inside of CIE as part of our housing navigation teams. So it is San Diego's like no other, but if not worse in our affordable housing. We've lost 35, 50,000 affordable housing units in the past 8 years.
Hi, Rita Fernandez of the Urban League of Long Island. I have a question related to that shared language and how you got to that, how you developed that, and what was your biggest challenge in sort of reaching a understanding of what that shared language would be.
Yeah, I was sharing with the team last night, and something you mentioned as well here, there's not, everything moves at the speed of trust, right? So I think that's something that when I say that this is a tipping point is that whether it's just agreeing to data share now, but also the trust part that we built, over the last few years. And then what we learned along the way, is this has changed. Shared language didn't appear in what we did probably 5 years ago. But as we're working, as this CIE trust network is coming together and meets regularly, that we realize that each domain, transportation is talking one language. Somebody else's, person-centered care is saying something else. Somebody else's outcome over here is different. What a bidirectional referral outcome is of acceptance or denial or then more data. So we realized that people were speaking different languages according to what not even silo, but the sector they were in. So it came together as a very collaborative, and I think that's the part is that when I mentioned we don't do this, alone, we get to be, the backbone, is with that group of people that started to come up with the whole index, the whole lexicon of, what that is, and there's a whole, it's in the toolkit as well as, there's other places, but it was very much a process of engagement that came up with WU, and then we also had to change our language, right? We were in a very information and referral, way, and so I think that, but that was a collaborative approach, and different domains and different sectors where the experts more than we were came together in bigger groups, and those are ongoing. The energy and passion around that room about how to use this and the continued shared language and the shared outcomes is tremendous. But it was in rooms together. It was in rooms together. There was no edicts that we could put over anything. It was a collaborative approach, making sure that we understood everybody's needs and received some consensus on that example. So.
Hi, good afternoon. I spent the first 2 weeks in San Diego of this year. It's a very beautiful city. I would like for you to speak to some examples that your organization works with schools. In Long Island, as we said, we have 124. You have 36, roughly, right? 18, and then 18 tribal,
yeah.
Right? Okay, so could you speak to some examples in all different ways that, not all, but a few different ways that you work with schools, or schools work with you, the exchange of communication, in hopes of lending us some direction in how can we work together, 124 schools throughout Long Island. Specifically, also, if you can touch upon STEM at all, if it serves a role. Thank you.
So we talked about this last night. So education, and when I talked about multi-sector, is probably one of the most difficult that we're having a time with. So we have connections to our San Diego school district. They have programs where some of our CBOs are in doing, there's work around veterans, children, active duty military kids in school. The United Way has caseworkers that use our technology inside the school, that work with parents. But we do not have, when I have education there, it's a place where it needs a lot of work. Not only because of the school districts, but what they feel because of their privacy and what they can do with student information or parent information. There's very much an outreach component. There's very much people are in the schools, will let you come into the schools and do work. We have those programs through the United Way that uses our technology, but there is not a consistent, they're coming, and we've had, as we go through our plan and our goals, we're having great discussions, and we have but it has not moved to what we'd like to see it move, that we need to feel that education can play a role in. And I'm happy to follow up that our team has thoughts and use cases around that for specific sectors, so I'd share that with you. Yeah, we didn't realize it would be one of the most difficult ones, so.
Morning.
Oh, there you are. Hi.
As a follow-up to that question, it was a similar question that I had was, some of the challenges, nomenclature, how you do things with technology, integration of that. One of the more important things that I continually see is that HIPAA word, and people, even our state agencies, social services work with the health department, but we can, locally, state will allow us to share information on common clients, which is a huge barrier, lost opportunities, and how do you, locally, it's difficult because everyone wants to have a waiver and cover themselves, but how do you even start that process?
Yeah, I think that's where, when I spoke about our County of San Diego and their system, which we actually have a little bit of difference on what consent into the systems are and what can be shared, whether it's behavioral health data, certainly eligibility programs. We have mapped out what for referrals. The county doesn't see that a referral as any type of protected information. These are, customers of the county that we have a partnership into CIE, and that information can flow for specific clients for specific purposes. So, and then some of it is, just known to the county, right? So each data use of each, over every sort of use case we have worked through with the county. We have been working in the Connect Well system for years. We're actually one of the only nonprofits that's actually in the system, and there's a referral component. And so what they decided to do is, since they are going to make it mandatory for all of their contractors to be in the CIE. So they have their back-end Connect Well system now connecting to CIE. So we still have work to do. The firewall went down, and the user acceptance training went live, and now we have a whole host of things to do. But the consent pieces that they feel like we have is in our consent now, which we are working hard on a universal consent. At the Workforce Partnership, at our major food bank that has over 400 pantries, at the Homeless Information System, and at the county, there's a uniform consent that people opt into to share. So it's a person's, has their own right to share information. So it's really, they control full consent, and that's why I think, in future discussions about the consent repository, whether that's government, or whether that's community-based organizations, a client has the right, even in healthcare, you're either opting in or opting out without even knowing it, whether you're sharing that into HIEs, right? If it's in but we've kind of gone through those hurdles. Our county is very forward in that there's information that can be shared, there's information that can't. And so I think it really goes to that, the uniform consent, and when a client comes into their program for services, when we consent in, or one of those other partners, there's a consenting in to share with the county with the purpose of what they can see for a data use agreement. So, our big concern was, what's probation going to do with this? What's Child Protective Services and Child Welfare Services going to do when someone's reaching out for, some type of assistance? They can't use this to deny benefits or do anything. So that's very much in the data use agreements and the consent. That's helpful. But, I've seen it across the country. Every place in Texas is getting pretty liberal about sharing. VA is, in San Diego, is getting a little bit more liberal about sharing into our veteran system. But it's kind of catch can, and whatever that culture of that. The ONC and some other things that come down said, you should be, HIPAA's meant to be, portable, and you should be able to, it's all depends on, again, how you're sharing it into what system too. We had to do a lot of legal and the technology work around, making sure we're compliant to the same level of electronic health record. So.
Okay, and this is our last question.
All right, I got two. Actually, I have a lot more questions than two. But, I've been involved with projects looking at platforms similar to yours, risk assessment and things of that, benchmarking, things of that nature. Two questions. One, what's the cost of developing the platform? And two, given the fact that you have a closed-loop system and you do a risk assessment, so you're able to look at performance or progress or lack of individuals as they enter a system, you've been asked to consider the issue of evaluating the services on a go-forward basis and looking at different providers and trying to help group providers?
Absolutely. So I'll do I don't remember your first question because I got so caught up in the second one. We actually have been, 2-in-1s in general have been able to see what programs and services have been working, right? By just the callback rate, say they don't answer, they say I'm not eligible, they send me back to you. So we are tracking. It's an interesting place to get into an evaluation mode of services. A lot of people want us to create a Yelp for our clients, and the clients, because they didn't like the services they were getting, even though they went to the right place with the right service, and they maybe had a bad experience, we didn't want that place. So we do see, and we're seeing, we have service level agreements with all of these, how quickly they have to respond, and then what the rejection rate is, and so we work with that with all rates. We always have as a 2-in-1. We've asked people to not be in our referral database because they're not providing quality services. So now with CIE and having outcomes, service levels, every one of them that signs that business associate participation agreement also has service levels of how quickly they have to respond. And as they're denying clients, we need to know the reason why. And that's a host of reasons. We have one agency that is just bad at their intakes, and they're just not timely and they're not organized. And so we've been trying to work with them in how can we give a better process. You're the only agency that does this. work, and we need to solve this together. So yes, as far as publicly evaluating and publish that, we haven't had a fund of saying, well, how are you shaming your partners? And like, I'm not sure. I said, working with them, at the deepest level of workflows and success is really where we're at this point. I don't think we're out for shaming them, but we are tracking very clearly, always have been, the quality of an agency as part of inclusion exclusion as a 2-in-1, and then the greater CIE partnership. There are very clear service levels and reporting and connection. And we've pulled partners out of CIE as well, saying, that you're not really performing at the level and the service levels there. The program doesn't seem to be truly activated. So, and what was your first part? Oh yeah. Ooh. All right. So remember, I told you we started work on this in 2011 from that Alliance grant of $1 million in innovation. And so they quickly came in the Invest Up strategy. And so they have spent $4.5 million over a period of 8 years with us. We've also received other investments, federal investments, and some veterans around this technology. I think the important thing to know is that's not the cost of it. That we actually, when we merged the two systems as it split off and became one of its own organization for a short period of time, and we said, well, this is not valuable, and we continued on our path. They had spent $2.5 million, and when we received the technology back, it was not functional. It was a different piece of technology, the consent management wasn't there, so we had to, great lessons learned, great expensive lessons learned, we're happy to share. Some of our mistakes, some of it doesn't really matter. They were, so we've done a lot of great things in terms of best practices. We also made a lot of mistakes. So it was costly having to do it twice, right? So the ramp up of the technology is not bad. It's not. I don't feel like a huge investment of those dollars now. One of the things I was sharing last night, it's not just the technology. We have 6 people in our whole organization, like 6 people on our CIE team. That integration of bringing on partners, workflow, data, and their business association, having them work in there, there's a people. It's a people and a relationship and a workflow. So our cost is not, now that it's up and running, but we're estimating that it's probably a million to 1.5 million investment to get up and running. Now, again, that was with having to recreate a whole host of things, having to go down. We spend $500,000 on legal. We had to bring on a chief medical officer. We have now a CISO, a private security officer. We have again, audits against the proper use and things like that. So that's really was the ongoing maintenance of it. It's about a $1.3 million a year now. Primarily, that's with, only less than probably 10% of that is technology at this point. Great.
Okay, folks, we're going to take a 5-minute break. 5 means 5. Okay? Because my panel's next. But go get some coffee, run to the bathroom, be back here in 5 minutes. Also, if you still have burning questions for Bill, he's going to be with us through lunch, so you'll have a chance to grab it then, okay?
Alrighty, ladies and gentlemen, at this time we ask that you please return to your seats. We are about to begin.
The Health Equity Alliance of Long Island. I've really been able to witness firsthand people's willingness and eagerness to shift mindsets, to consider a different way of working with each other and within our own agencies, and to step out of our comfort zones and really imagine a different kind of Long Island. And I love how Bill's presentation really set the stage for the potential of what we can do here in our region. So I am really, really excited about people sitting here with me. These are some of the folks who have been deep in the trenches for the last year and a half or so. And every single person sitting up here has had a really valuable and significant role in the work that we've been doing. So I'm going to start off by just asking each of my panelists to give a brief introduction and describe their connection to Healy, and then we're going to get right into our questions. And at the end of our discussion, we're going to save about 10 minutes for another Q&A, so all of you will have a chance to ask our panelists some questions too. Okay? So I'm going to get started. Matt, what do you think?
I'm Matt Brown. I work in Yorkville Health's Population Health Informatics Department in my last 4 years focusing on district, and I've been a member of Healy for about a year, working on the data and technology committee.
Good morning, I'm Greta Gorton, the director of the Long Island Coalition for the Homeless. The Coalition for the Homeless is a Tier 1 CBO with training contracts and outreach contract. And we have been members of Healy for the last year and a half, and I'm on the steering committee.
Hello, everyone. My name is Thurston O'Neill. I work at the Institute for Parenting, project coordinator for the Closer to the Crib program. Been a part of Healy for the past year, and on the community engagement.
Good morning, everyone. My name is Alex Horowitz. I'm the principal technology strategist with Intrepid Ascent, which is a consulting firm that works with Healy. We're a California-based firm, although I live in Brooklyn. And we're helping Healy with a landscape assessment of what technologies are being used by the various community-based organizations in the community and helping to plan around that bold vision that Rebecca was talking about earlier about trying to find ways to share information on Long Island for better health equity.
Great. Okay, so we're going to dig right in. So in the beginning of the morning, we heard Rebecca talk about our segregated region a little bit and some of the challenges that we face. So I want to ask you all, what, if any, improvements have you seen when it comes to health equity? Let's start with the positive. So what kinds of good things have you seen happen? What, if any, were the drivers of those improvements? And what do you think are the biggest gaps? And what do we need to do to move forward? So I'm going to toss this first to Thurston and Greta, because you guys are the two CBOs on the panel. So either one of you want to start?
Because you started with a difficult question.
Oh, come on. It was loaded with lots of little questions, so you could take one piece of it if you want.
I honestly think that in terms of, I'm going to take the end of your question first, in terms of the challenges related to health equity, I think that there still needs to be a lot more work done around not just connections with various CBOs, but the recognition, as Rebecca and Colleen said, of the work that the CBOs are doing, and ensuring that that is connected with the work that's being done by the healthcare systems. We are not recognized for the value of the work that we do. I also think that with respect to where we're moving towards, a lot of the work that Healy has been doing, conversations with Alex, in being able to create a better connected system technologically, and Bill, we want to do what you're doing, we'll be able to move our community forward in that area.
Thank you. Kristen?
I agree. I think we're at the beginning stages of some very powerful changes. When you ask what changes I've seen thus far over the past year, I cannot put my hand on really concrete changes that I've seen, but the conversation and what we've engaged in at the Healy meetings gives me a lot of hope for where we're moving, and I definitely see us moving towards something like Bill is describing, and I think we are, this is the beginning of something really big, and I'm very hopeful about the changes that are about to take place here.
Great.
You know, it's been well established that there's a lot of work to do for health equity in the community-based organization space. I would say from a health provider perspective, specifically with district, where, as we discussed already, the money went to the health systems and then it was supposed to flow out to the community, and it's been a difficult challenge to do that in a lot of ways, despite a lot of well-meaning people. I would say the first few years of district, we were moderately successful in flowing money and support at least to small primary care practices, so still in the healthcare delivery sector, but at least trying to spread the expertise, resources, and money outside of the centralized health centers such as Northwell and into more small primary care, which is a critical access point for a lot of folks who live in the communities. So although we have a lot more work to do beyond that, I think at least as a positive mark, we were able to make some headway in the direction of flowing from bigger down to smaller.
Alice, do you just want to elaborate, maybe make some comments about you have a sort of a broader experience beyond just New York?
Sure, yeah. So, and I should have said it during my intro, but I've worked with some of the district programs in upstate New York, in Rochester in particular, and also in Syracuse. And in California, our firm works with 6 of the whole person care pilots that Bill was talking about, that one of which is working down in San Diego. And I'll say that, this community on Long Island has a huge opportunity from what I've seen. I've only been working here with you for a brief period of time, in that many of your organizations are eager and interested in working together to share information. This is not, people aren't throwing up too much of the HIPAA, cop-out. There's not a lot of too much anxiety about sharing information. There's a lot of desire to do it, but one of the most significant challenges that I've seen is that there are no good mechanisms on Long Island for doing that. There's no good technology mechanism, there's no good single organization that's coordinating the sharing of information or coordinating referrals or transitions between organizations. And so there's a lot of eagerness. There's certainly a need across the country, as well as here in Long Island, to be doing that. But you're poised to move in that direction, but there just aren't any good systems in place today to do that. And it's unfortunate that, as Nat said, that district didn't make that happen for communities in New York State. I think that what Rebecca said earlier, and what others have said, is that there needs to be more investment in this area. There needs to be more opportunity to build it out. It has not been provided up until this point, but I think that you're poised to move in that direction.
Great, thank you all. So now we get to my favorite question, and some of you have heard me ask this question, but it's my magic wand question. So if you had a magic wand, and I'm giving it to you right now, what changes would you make to improve access for the communities and families that you serve? So, Alice, I would probably ask you to sort of give some perspective about what you've seen work really well, but for the other 3 folks on the panel, if we could do anything, what do you think, based on what we know is happening elsewhere and what we've learned so far, that could happen, what would you like to see? So I'm going to open up to anybody who wants to jump on that. Kirsten, first.
I think one of the first things we could do is ask Mr. York if he has time to come over here to Long Island and implement some systems for us. But seriously, the integration of a system that connects us all is critical, because we are operating in silos all over Long Island. We have, I would say we have a lot of good programs, a lot of good people that are eager to help, but we are segregated, we're separated. And, this is about health equity, having everyone have the ability and access to good services. But I do notice that a lot of people fall through the cracks because we have no system to hold one another accountable. One of the big things that Bill was talking about was really looking at the services that are provided by the organizations that are part of this organization there, and not just saying, okay, you're not doing a good job, you gotta go, but stepping in and trying to help them and provide better services to bring their services up, not just push them out and say you can't be part of us. I think that's a big part of what we need here on Long Island. We need that integration of services and accountability as well.
Can I go next?
Yes, you can.
I'm going to stick with the magic theme here. If I had your magic wand, I would speed up time, because I do think that this is going to happen. We've been working at on Healy for a year and a half, and there is momentum building, and I think today is going to be a big springboard for that. But it just takes a lot of time. Everybody's got multiple things going on, and everything takes twice as long as it should. You know, the truth is, with technology, anything's possible with enough money and enough time, and we don't have enough of either, right? Unfortunately. So, you know, maybe this summit is the magic wand that will spur us into speeding things up, because as Rebecca clearly laid out, people don't have enough time to wait for us to get our act together. And we will, but how long will it take?
As I mentioned, the coalition has 2 district contracts. One of them is for a trainer. I'll explain briefly what that is. And the other one works with high utilizers of hospital services who are homeless using Newman, through Newman. The coalition also runs something called the Continuum of Care, and we do, as I mentioned, we do housing placements for the homeless into permanent housing programs. I mention that, and it's relevant because we also manage the homeless management information system in our region. And some of what I've seen in the work that we've done through those 2 district contracts, our trainer actually trains people for that referral process. Has been tremendous successes in the work that we've been able to do in the number of people who are homeless, unsheltered, and high utilizers of hospital services to get into and stay in permanent housing. We wouldn't, anecdotally, we would know what we were doing. We wouldn't have the metrics without the database that we're using. And I speak to so many people that they have some information in databases, a lot of information that's not in databases, it's on, you know, handwritten spreadsheets. And when we're talking about trying to integrate services or make appropriate referrals, we're great within our own system, within the housing system. Not so much referrals to other systems. I am not a tech geek, I am not a data person, but I'm recognizing that when we have those kinds of systems and that kind of data, we can push things forward in a way that I didn't have any idea we could do. When Matt's talking about pushing, you know, that you want to speed up time, I agree. One of the things that is so important about the data that we actually have is we're not just looking at a snapshot. We can see from longitudinal data how long people have been homeless. That helps us make decisions on a local level. And that's true of every system. I can only speak to it.
So just to follow that up really quickly, so if you could envision where this is all going to go, and if you had that sort of picture of what
We're moving to San Diego.
virtually. So can you, in a sentence or two, just what would you like to see?
I'm Cuban, I can't say anything in a sentence or 2.
I think that good integration of a good system like this one that allows us to talk to one another is essential. I also think that there needs to be a lot of support, especially for those smaller agencies that are not accustomed to using databases or capturing information or have the infrastructure for that. We need them to be part of this, they need to be part of it, but we need to be able to support that financially.
I think, you know, the holy grail of this type of coordination in communities across the country has been a single longitudinal shared care plan for an individual that has all of their basic needs, their social determinants, their healthcare needs, all in one place, so that individuals and organizations can coordinate across the sector on the individual. That is something that you could get with a magic wand. But I would say that, you know, the journey to get to that point is just as, if not more important than getting to that point for a community. Each community is different. Every CIE that's being talked about or implemented, every HIE, every care plan is different and reflects the community that's working on it. And too often I've seen communities move too far too fast and basically try to get to the end before they've taken the journey. I think this community here today and over the last year, and will continue to be on that journey and take a stepwise approach to getting there. I think the first thing to do is to find the one or two most important things you can do to create those linkages. I think there's some great examples that have been thrown out today, and do really well at those things. Do understand what workflows, what systems, what ways of sharing information and working together are going to be the most effective, and build on that instead of trying to go to the very, very end too quickly. I'm not saying to not look at that, shining city on the hill and admire it and try to emulate it, but really work on that global journey. And I think that, as I said, some of these ideas are really great.
Great. Okay, so let's talk a little bit about what local or state systems or policies that are in place right now that are supporting the efforts and the work that we're all doing. You think of things that you found, from a policy position that is working, that's helping us involve. Are there examples? Support.
Certainly district, at least I wouldn't be here without district. A lot of us are here. District is a massive, very well-intentioned, and in some cases very flawed system. And I think the folks who designed the district, the New York district system, had choices to make about what they prioritized, and hopefully, if we're able to continue to do this for another 5 years or another 2 years or whatever it ends up being into the 2020s, we'll be able to do this work, building off of the infrastructure and groundwork that we spent the last 5 years working on. So I think, it's easy to say, oh, the district should have been better, and yes, it should have, but there was a lot of good that it did help bring a little bit.
I just want to remind everybody, because we have acronyms, and I see my boss nodding repetitively. DSRIP is really New York's manifestation of the waiver that we received from the federal government it was that 5-year thing, that the 5-year project that Colleen mentioned, to reduce avoidable hospitalizations and ER visits by 25% over 5 years. And we are in year 5 now of DSRIP. So there's some conversation at the state level about DSRIP 2.0. The actual acronym, I don't always get it right.
Delivery System Reform Incentive Payment.
Yes. So, and what's so interesting is, of all the states in the country who have this Medicaid waiver, to do this transformation work, not everybody calls it the same thing. So it's really distinct state by state. So you want to really get confused, start doing some of that research. But here in New York, that's what we call it. So that acronym, but what it really represents is the Medicaid transformation, and a lot of the work and the funding for the grant under which we formed the Health Equity Alliance, or HEALY, the funding came from New York State through DSRIP funds. So everybody's with me, right? Yep, got it? Okay, good. Okay, anybody else want to talk about policies or systems that are working right now to support our work?
Also, I just want to tag on top of that district comment just very briefly that I probably wouldn't be here if it wasn't for district either, here working in New York State on this type of work. But it did really expose, through a flaw that it had, the massive inequity in investment in social services and provision of social services. It should be obvious to the state at this point that that was inequity, and the next phase should learn from programs like in Massachusetts or in North Carolina and California that have all invested heavily in social services. So I think there's a massive opportunity there. And I also want to say that, and this is putting a little bit on the spot right now, but your HMIS, Housing Information Management System here on Long Island that the coalition runs between the 2 counties, I've seen many of those systems throughout the country. This one is very good from the perspective of it's integrated between 2 counties. It is capable of sharing information with other systems in a more standards-based way than many other HMIS systems have been. And so I think that you have a good piece of infrastructure there that could be built upon or used or worked with that affords you an opportunity for your housing providers to provision housing in this community that many other counties and communities may not have.
Thank you, Alex. Okay, so,
I just want to add to the statement about Disrupt. Over the last year and a half, when maybe it's been a little longer, but when the CBOs did start to get more involved, I actually think that it's been wonderful. Again, we have 2 programs that we've been able to see amazing successes because of the data we have at HMIS and what we've been able to input. What I'd like to see, and I hope there is a District 2.0, there's so many successes going on. I'd like to see more ability for those CBOs to be able to share what they're doing with one another in a larger forum with the NCUs also, because I think we're not seeing that. You know, we're just at that point, but we need to keep moving forward for this to be a truly integrated and successful system.
2 more translations for you. CBO is a community-based organization, otherwise known as a nonprofit agency. And there's a lot of folks in the room who work for nonprofits, primarily in health and human services, behavioral health, but that's a term. And then the other one is MCO. Does anybody know what it means? Managed care organizations. And I also want to just add one thing about this that just occurred to me is when I think back on when the Health Equity Alliance started meeting and we got that first group of folks in the room and we did, our first list of what do we do really well as a sector? What do we need to look at as a sector that maybe we could do better? And then we asked the magic wand question. One of the things that impressed me, and I know impressed the other folks from Health and Welfare Council, was how readily people were able to step out of the mindset of my organization, what's good for me, my organization, my funding, my sustenance, and what do we need to do both as a sector and as a region so that we can improve care and service delivery. I thought that happened really, really fast. So when we talk about, something good, another good thing that came out of the initiative from the state, it put people in the room to have conversations that they weren't having before. So I think that was a really big positive. So
just to add on to that, to go back to Alex's point about the journey, and I think you're going to ask about successes and failures in a minute. Maybe this would be a good segue, but Disrupt allowed us to succeed sometimes, but it allowed us to fail other times. And I actually think failures can be really good if you can learn from them. So just to harken back to the journey point, we a couple of years ago, many of the health systems in the downstate region got together with the Health Information Exchange, a couple of the HIUs actually, and we said, okay, with technology, we should be able to have a single care plan that all the health systems can use and share into the cloud, and one care manager can share with another, and all interoperable, so shared patients can be care managed collaboratively. So we got together, and we did that. We actually created a shared care plan that all the health systems could access with the same language. It took about a year. Technology was great. Put it into the world, Northwell, Mount Sinai, other systems, Catholic Health Services, and guess what happened? Nobody used it. Because we didn't really ask the care managers what they wanted or why they would want to do this. We just assumed, being technologists and other leaders, that, yeah, this is a good idea, we should do it, right? We didn't take the journey to actually engage stakeholders, engage the frontline staff, talk with people who actually do this work. We didn't ask them, do you need this? And what would you use it for? What should it look like? And that was a real learning lesson, I think, for a lot of people. That failure, which District helped fund, hopefully we can learn from that and not make the same mistake, not design a community information exchange system from the top down that doesn't really address the needs of the actual users of that system.
okay, so before we get to some examples of how some of this transformation work has been successful and not successful, I just want to stick with policies and systems for 1 second. If there were a policy change or a system change, again, either at the county or at the state level, that you would like to see, that you think would help move this work forward in a good way, do you have any ideas? I don't want to put you on the spot first.
District 2.0. I think that there needs to be a continuation of this conversation. I think there needs to be continued funding, but with the focus of engaging more of the community-based and the nonprofit organizations, and make better connections with those community-based organizations, with one another, and with those in the hospital system, so that we can truly have a better connection across, all systems related to the folks that we're serving.
Financing is key. Money is key. And that's what will keep the work going. And as Mr. York was speaking earlier, and he gave the numbers about what it would cost for them. Actually, I was surprised. The number wasn't as high as what I assumed it would be. So if there's funding available, just for the 2.0, and more funding put towards these type of efforts, I think it would help us move the needle quicker. Not that I want to jump to the end. I mean, I do want to jump to the end, but I do understand there's a process to getting there, and you don't want to make mistakes, but we can learn from mistakes that other people have made to get to where we need to get quicker.
I think that so one of the big slides, there are a few slides that illustrated this in Bill's presentation, where there were sort of the iron triangle of three different sectors. There's sort of the social services sharing, the government county, in the case of San Diego County, and then the healthcare HIE sharing. Those circles are not as close to convergence in most of New York as they are in San Diego right now. I think in addition to a lot of the work that can be done among the Healy members to try to find a way to share data amongst yourselves to satisfy one of those circles, having the state change its approach to how the role of what you call RIOs, Regional Health Information Organizations, which we call HIEs, Health Information Exchanges in other places, to give them permission to share information around social services, give them funding to do so. I know that they don't have a funding stream for that, and also behavioral health care data, which is sort of all still separate, would go a long way to helping to bring things a little bit closer together and get to a more comprehensive, person-centric sharing of information. And I also think that bringing in, county governments are different here than they are in New York, or in California and other places. They have different powers and latitude. I understand that, but getting local county government involved is going to be extremely important, especially local health departments, which epidemiologists are. Are there any epidemiologists in the room today? That's what I thought. None. They're often not invited to these conversations. They can be powerful champions and have a lot of interest in the whole person, the whole individual. They often realize the value of, understanding social determinants of health and track things like food deserts, all those sorts of things like that at the public health department. So they're really important to bring into the conversation as well.
Okay, so we're going to jump to successes and failures. I'd love to hear some examples from all of you. In ways that under this Medicaid transformation initiative by the state, we've alluded to a couple, but if you have some very specific things, attempts at, we've talked a lot about, needing a bigger scope of collaboration and sharing, but I know there have been some smaller projects, so do you have any others to speak of, or examples, or things that you've heard about that you think have either worked really well or not worked?
Actually, Greta and I worked on a project a couple of years ago to connect her organization, Long Island Coalition for Homeless, to HealthX, which is our Regional Health Information Organization, or HIE, as Alex was just describing. And we had a really, really strong reason to do it. We thought having the housing service and homeless information data in the clinical health information exchange network would be really beneficial to the health system as well as to Greta's organization. And we had buy-in from Northwell and from Long Island Coalition. We went out there, we did a lot of explainers about it, and it failed, right? And it failed for a number of reasons, but I think the primary one was probably me, didn't focus or didn't succeed on building trust. And learned, my biggest takeaway from that failure was it really, the majority of the effort in any technology implementation is people, really. It's you always say people, process, technology. People come first because that's the most important thing in building trust is kind of key to that element. And I would say Healy is a success because Healy is that mechanism to build that trust. And although it has taken, a year and a half to get to this point, we're close to the point where we have that trust. We can actually start bringing the technology into play. Technology is the last step. Technology is easiest, honestly, if you can get the people in the process.
Just building on the discussion of trust, extremely important, and actually during the break there was some more conversation had about, certain communities have not, they don't trust systems because of our history and the way, and being on this panel, I think it would, I can't pass up the opportunity to speak about that. To speak to certain communities about how information will be used, because like you said, it's all about individuals. So the individual has to buy into sharing the information. Yes, take my information and use it. But will that information come back to me, like we spoke about, through probation, through CPS? How will this information be used? Can it be used to harm me or harm my family? And I'll tell you, when you have these conversations about sign off the right for us to share the information, most people in certain communities are automatically going to say, no thank you. Even though it can be helpful to their family, but because of our history in this country or in this region, there is a sense of, in order to keep myself safe, I'm keeping my information to myself. So being able to send out viable voices into those communities, people that they know, people that they trust, to explain to them how it's going to be used. And one thing that Mr. Yoke talked about was how they hold even the government agencies accountable to how the information is being used, and they give reports on how it's being used. If there's any negative usage of the information, they want to know so they can put a stop to it. That's very important in being able to get not only organizations to sign off, but individuals to sign off on sharing information.
I just want to elaborate on something that you said there, so thank you. One of the things that I heard a lot in the beginning from our Alliance members was that oftentimes projects will come, talk about top down, somebody will swoop into a community and say, hey, we have this great program, and here, do this, and then it doesn't work because there's been no buy-in, there's been no trust building, there's been no questions asked. Do you need this? Will this help the folks in your community? Actually, what will help the folks in your community? What are your needs? So then, they pull out and that community's left in no better situation and feeling a little burned, quite frankly. So I think the piece about trust building and about program fatigue is critical, that we are mindful. And I think when we developed the mission, vision, and goals of the Alliance, we were really sensitive to making sure that when that time comes, we don't make that mistake. So,
everywhere I've been, top-down approaches to changing communities and building that trust don't work. It just doesn't work. And that, I think, includes a really important concept that you touched on a little bit, but so in some communities they call them clients, sometimes consumers, but the individuals who you are serving need to be a part of that grassroots effort to build the solution. You as care delivering and service delivering organizations can yourself be top down if you don't include the client in the process of building that up and including them in the trust building. So I think it's great that you mentioned that, but I just wanted to say that it's true for other communities all over the country that are trying to work on this. When they try to go top down, it does not work.
Okay, so before we get to some questions from the audience, so you have a room right now full of practitioners, medical practitioners, behavioral health practitioners, nonprofit organizations, health systems, managed care organizations, local government officials. So you have a chance now. So what do you think the one thing is, maybe two if you're ready, that when people leave the conference today, they're thinking of a voice of creating, helping us to create a more equitable system? What's the thing you want people to walk away from thinking and doing to help us keep this ball rolling after today? Any ideas?
Stay engaged in Healy. This gathering of organizations and individuals is impressive for any community to bring so many organizations together, especially when it's not, and not to dig it too bad or any of the healthcare system, but when it's not a hospital that's hosting everybody and trying to bring them together. This is a grassroots effort from what I've seen so far, and I would say that staying engaged and pushing Emily and others to continue to move forward in the planning process every step of the way is the key to success, the key to continuing on that journey.
Anything else?
Similarly, there are a lot of people in this room that have a lot of meetings with a lot of people, some very important decision makers. I believe that Healy and the work that we're doing needs to be on the tip of everyone's tongue. We need to talk about it. We need to talk about the diversity in the room, the different organizations that have come together that are buying into it. I would also give a plug for our Healy portal. So the Healy portal that was set up, although we're not at a point where we're sharing data or anything like that, I personally use that portal to look at other organizations around Nassau County, Suffolk County, that I can make a call to and say, hey, I have a client that needs this. What is your process like? How would I refer them over to you? So even though it hasn't been fully set up for data sharing and such, I use that portal to help me in my daily work. I think it's important as we leave it, if you're a part of Healy, that you engage in the portal, that you get to know who else is a part of what we're doing, and have these conversations when you have your meetings with people that matter. Talk about the work that we're doing.
Ready? Thank you.
And I agree with what both Alice and Thurston just said. The other thing is, we know the folks that we serve, right? We understand probably better than most what their needs are because they are telling us. We need to make sure that Health and Welfare Council and Healy hear that, and we need to stay engaged in that so that we can continue and they can continue to bring that message up.
I would just say, let's do it. Let's not wait for District 2.0, not wait for the state, not wait for anyone. We can do this on Long Island. And let's be a model for the rest of the state.
Okay, so we have some time for questions. We have our mics out there. Oh, Tommy Grace has someone in the back. Yep.
So I have a question, and not really a question, but a comment, that on Long Island, we have these terrific organizations. Healy is one, Long Island Health Collaborative is one, District Northland is very great, so Stony Brook District is also great. But communication is the key. You all have similar agendas. We are part of all of them. I'm a CEO. I represent Cornell Cooperative Extension. I work with food access and food insecurity. I'm in the business of education. But I belong to all of these organizations doing the same work, have the same goal, but I cannot attend all of these meetings that we have. So why don't all these organizations that are doing the same work have some kind of communication and make it easy for us in the partnership to come and work with you all and have a common goal, rather than divide all these up into silos and we have to belong to all of them. And today is a fine example. I belong to Long Island Health Collaborative, and it has this meeting today, and you have a meeting today. So we could even get that clear that we shouldn't have a conflict. We belong to both organizations. I'm a member of EE, I'm a member of Long Island Health Collaborative, and it shouldn't happen like that. That is a concern as a CEO I really have.
That's a really good point. Thank you. So hear, the comment was about how there are some other initiatives happening and that we should do a better job of communicating. And to that end, I mean, we try very hard to share meetings and information. I go regularly to the Long Island Health Collaborative, and we work collaboratively with them and with other collectives and groups. I think, and you guys can debate whether this is true or not, but I think that as the Health Equity Alliance continues to grow and we continue to, expand our membership, some of that repetitiveness can probably be much more, can be better avoided. But thank you. I think that that's a really good comment, something we can be mindful of. Any other questions?
I am Joy Williams. One thing I notice in meetings where we talk about health equity, and often when we're also focused on district, we have a conversation that focuses mostly on the Medicaid population. But when I look at health equity and look at the problems, the disparities in the African American community, and let's just take maternal and infant mortality for one, it crosses all socioeconomics. So often I feel like we're creating programs that wouldn't work for the other side, because even in changing the names of them, I think sometimes it's good. Because people who think they have the services that they need wouldn't be looking for a program that seems to be targeted to someone who's on Medicare, right, or Medicaid. They wouldn't do that. So I'm just wondering how we can, even if that's for the target, we can keep that in mind, that really to provide health equity is to take that step. So it could be a scalable system, and it could really reach more people and really provide a reduction of outcomes. Serena Williams, for example, would not consider a program directed at a Medicare population, and she had problems and she had personal issues. So I'm just wondering if you have any examples or any suggestions on how to do a better job of that.
Sure, I can speak to this just a little bit. I think that's a really excellent point, and it can be challenging for government, the entire system, to get out of the mindset of Medicaid, that is Medicaid individually, because that's how most of the money flows, unfortunately, for many of these programs. Now, Healy and HWCLI are not necessarily constrained by that funding stream, as a district might be, for instance. That money all flows down primarily through that funnel. So I think that you have an opportunity to break out of that mindset a little bit and to think about maybe the whole individual or person-centric care and health in a way that leaves out, Medicaid is an important 20% aspect of that according to Bill's chart, but it is only 20%, and so the rest of that can be thought of outside of that context. And I'm not sure the way that many of your organizations may receive Medicaid funding, so it can be challenging for you as well to break out of that mindset. But I do think that that is a really important point, and that some communities are starting to think about that, but until the money flows differently, it's going to be very hard to break out of that mindset.
Any else have thoughts on that? I mean, I think about Angela Glover Blackwell and her cuts philosophy, right? So, when you start focusing on a population that has a particular need and you meet those needs, and then that ripple effect that people benefit. You think about how smoking stopped on airplanes because flight attendants were being subjected to secondhand smoke, and now we all benefit from non-smoking places, right? So your point is really well taken, and it's actually come up in our alliance meetings more than once, that how will we make sure that what we're doing certainly helps targeted populations, but also can help all of Long Island, because, you're right, it crosses over socioeconomics and different groups. So I think that's really important that we're mindful of that as we continue with this work.
I think it's also important to keep in mind that the onus doesn't just fall on us, because we have a lot of organizations here, but there are a lot of organizations that are not a part of what we're doing.
Not yet.
Not yet, right? And I believe there are many organizations that have a mindset of, if this work is not directly affecting what I do, then it's not worth my time. And I believe that it's important to understand that the whole ripple effect. The ripple effect is, if I'm a part of getting things done here with Healy, with Health and Welfare Council of Long Island, the ripple effect of the positive steps that we make are going to affect my community, the people that I serve, the population that I serve. It's going to have a positive effect on their lives. Even if I'm focusing on housing and what we're working on at a particular time doesn't focus on that, the ripple effect may be that they get rid of the food deserts in the community. They get rid of, or they provide more mental health services in a particular community. That's going to help my family. That's going to help the population that I serve. Even if it's not directly what I represent in my organization, I still want to see the entire population served. That's what health equity is about.
Other questions?
Wendy Jameson, I'm with Intrepid Ascent, work with Alex. And I just wanted to first put a pin in that thought around how we've kind of lost, in some ways, a focus on racial disparities as we've moved to health equity. I think that's the first time I've really thought about that. And I have a very practical question, really, for Greta and Thurston. So if we're moving, as Matt says, let's do this thing. Let's start sharing data. I'm curious about, in your nonprofits, when you've had success with a change, like a technology change, an adoption, and kind of what made that work? And any thoughts there?
A lot of Band-Aids.
When there's funding behind something, it helps create the system that's necessary. You can't do it without the funding. Sadly, when you can't run the system without the funding, and the funding is mandating those changes, then yes, we find a way to make those changes. I'm not necessarily advocating to force that piece. I think it's more important that we focus on it together without it being a mandate. But it certainly is easier when there's a
One more question, and then we're going to break lunch, which I know I see other hands, but we have to stay on time. I'm so sorry, but we're going to take one more question.
So, Nancy Copperman, Northwell Health, and as a registered dietitian, I will get us to lunch. It's a comment on what was said before about like looking at certain populations within a community. So, Rebecca said we have pockets of wealth and versus, pockets of poverty. So, I think that we have to kind of look at our communities holistically and not try to separate different pockets out, because at the end of the day, what's done for one lifts everyone up. So we want to kind of rise all boats. So kind of going back to that idea, there is another movement on Long Island that's a national movement, Let Me Grow. And that really is looking at early childhood and connecting with services that's agnostic of necessarily socioeconomic levels. We're part of that, and one of the programs is called Family Connects, which is a universal screening program for all new moms, or really it's every mom who delivers. And it's agnostic of SES. It's really, would they like to engage? And then they have home visiting, and then they get connected to network within the community. So I think that's another resource. And they're looking for an electronic way of managing kind of their referrals that lifts all boats. The other thing that I was listening today to say, like, what other partners are not here? There's another kind of movement that's going on out of the Long Island, it's with the Long Island Collaborative Funders out of the LICF. And what they're doing is they're bringing together all the financial institutions, and there's a whole anchor network or anchor institution. And what does that mean is that we have a lot of employers on Long Island. Northwell is one of the largest employers on Long Island as well, that can actually move the economic status of communities through
through local hiring, local buying, and local investment, place-based investment. And the financial institutions, such as our banks, they have community building regulations, just like hospitals have community benefit. And wouldn't it be really great if somehow we could take this anchor work, wrap it around kind of the other work that Healy is doing, and then, as Zareen said, kind of bring in these other coalitions? Because if this is going to be truly successful, having all the money and the interest and the passion come together might actually fund and kind of gets in Matt's thing, like, let's just do it and move it forward. So it may be that we need to all spend some time in looking at like priorities and seeing where there's synergies and then move from there. So I won't delay lunch anymore, but just kind of thoughts.
Okay, so we're going to take, I was just informed, one more question, and then we really genuinely are going to break to
It's a super quick question. I was just wondering if there's been any conversation about trying to get a 211 system on Long Island off the ground. And if so, how?
We have one. There is a 211 system. There is? Yes.
It's 211.
Okay, but that's, it's a different kind of system than what Bill described. So Bill's organization is a 211 that's separate, and we have a 211 system under the auspices of United Way, and it's a referral system for the most part, right? And that's where it stops for the most part. Did I describe that accurately?
So is there, yeah,
It's not a community information exchange. So Bill's organization is a 211, is called San Diego 211, and they built this community information exchange, but it's not the same thing as 211. And he said that in his presentation, that there are all different kinds of 211s all over the country. I've been to other conferences, and they've manifested very differently, but here on Long Island, our 211 is distinct, significantly distinct from what the community information exchange that Bill described in his presentation.
So has there been any conversation about integrating that into trying to create this information sharing?
Yes, actually, well, just to answer this, how we first engaged with Bill's organization was we received this mentorship that Bill alluded to work with San Diego 211 as a model for developing the same type of program in Long Island. So actually, yes, the plan is, or at least the vision is, to develop something comparable, or at least follow the model of San Diego 211 to build out here. I think that is the plan.
And there have been, so I think Bill had a good point that you've seen 1211, you've seen 1211. They're all very different. Even the ones under United Way, which the majority of 211s in the country are under United Way. I would say that I've seen some of those that are very myopic programs that are not really doing very much at all, sort of a glorified phone book. And then there are some United Way 211s, like in Monroe County, up in Rochester, they're really actively have gone out and done some of what you said around getting local businesses to put in money essentially unattached to Medicaid in order to fund a CIE-like initiative. They call it the SIE system integration pilot, I think. And they're trying to build something similar with 211 from United Way as sort of a central component of it. So I'm not saying that is exactly the model to replicate here, but I'm saying it can be done, and it's a really good idea.
Okay, so I want to thank my panelists. You guys were awesome. So we are going to break for lunch, but here's how it's going to work. We're going to have a little bit of a working lunch. You guys laughing at me. So lunch is being served back in the room where breakfast was served. We want you all back in here at what time, John? We have till 12:25. You can bring your food in here. We're gonna have a really robust discussion about the state of equity on Long Island with some really amazing thought leaders from the region. So, but you can bring your food in and eat, so you don't have to finish and come back. You can bring your place in. But if everybody can please be back in your seat at 12 and ready to go at 12:25, so we can get the panel going. Okay? Thank you all. You guys are good.
So I'm going to introduce our extraordinary lunchtime panel. We have such a treat today to have these extraordinary, really public servants here to talk about equity on Long Island. worthy to even introduce one, but she's the regional director of the NAACP, among many other amazing things. Next to her is my dear friend and a true innovator in Suffolk County Sheriff Errol Toulon Jr. Next to the sheriff is our Nassau County Controller Jack Schmierman, who has been so committed to looking at equity in Nassau County and really producing data to share and help us understand demographic shifts in the region. And next to him is Marianella Casash. She's the Assistant Police Commissioner of Community Engagement and is doing an incredible job in Nassau County in making sure in a time in which demographic shifts have been so significant that we're bringing everybody to the table and that we're making sure our police are serving all of our communities. So welcome to everybody and thank you.
Well, let's kick it off. Let's get to the essential question. In your view, what is the state of health and social equity on Long Island? Don't everybody jump at once.
I'm happy to start, and I'll say there's one word to me that describes it, and we can build it there. And the state is gaps. There's huge gaps. We have equity gaps, we have wealth gaps, we have achievement gaps, we have health gaps. We can talk about all sorts of gaps, and we put out a series of reports to talk about that. But I think they have to start with the concept of gaps that work together.
Gaps. What do you want to add?
I would say that we're really in a place where we're quite stagnant in our growth and our ability to really capitalize on all of the resources that we have on Long Island. I'm talking about human resources. I'm talking about the power of diversity, the power of diversity of thought, diversity of experience. So everything that I'm going to talk about really has to do with the fact that we need to start looking at things through a different lens. And in all of our workplaces, many people don't have that lens. They either have not been exposed to it or they don't understand it. And I want to challenge people to think about cultural literacy as the same thing that you have to do as a skill for computer literacy. You have to learn Excel. You had to learn how to navigate the internet years ago to be successful in your career. Cultural literacy is another skill set that is very important in order for you to be able to have a competitive edge, especially in the state of New York. And I think in terms of equity on Long Island, there's a serious gap, to use the county controller's terminology, in that aspect. And I think there's an opportunity really for us to grow there.
I would add the word complication, especially in terms of the health system with equity. I'm still floored that my doctor has a hard time coming to the hospital to see me running. That's just odd to me. I understand it, I understand the reason why, but I think as we try to change things, they become more complicated for the residents of Long Island.
So when you couple with everything that you just heard, and you think about the most vulnerable population of individuals who are incarcerated, who really don't have access to the health care of individuals who they may want to see, think about the costs that taxpayers are absorbing. You know, I'll just give you an example. As of Monday, I had 6 individuals over the age of 70 that's incarcerated in the Suffolk County facility. I had 42 between the ages of 60 and 69, and I had about 130 between the ages of 50 and 59. And so we're starting to see an older population that's incarcerated inside, which is really a bigger burden to the taxpayers because of the various tests that they may have to go through than the younger population that's incarcerated. So it's something that's very challenging for me to try and see what we can do to offset certain costs, you know, just for our taxpayers, and also get them the adequate care that they need.
How complicated is it to take a look and address some of the issues that you raised when people from outside of Long Island take a look at Long Island and think suburb equals rich equals you all don't have the problems at all? How do you include that?
I think the first thing is by making people aware. You know, the sheriff's office is making people aware of the human trafficking issue that's going on in Suffolk County. And so I've been able to go to Washington and actually speak about the healthcare concerns, not just for Suffolk County, but really across the nation. And when you look at the cost, when you look per person, the amount of cost with diagnostic testing, with visiting the clinic, and maybe even being transferred to a hospital, you know, for a particular type of care, it's really a burden. So we really need to look at not only the cost, but also get more people engaged in the conversation.
So in our office, one of the things that we can do to sort of help that conversation along is to talk numbers. So let me throw some numbers at all of us real quick. We have a $24 billion with a B, $24 billion racial income gap on Long Island. So that shows us right off the bat we have some serious work to do. What drives that? Education. We see numbers like Latino residents in Nassau County have a high school graduation rate 20% less than overall communities. You have, we look and see when young people are leaving high school or college, the black teenage unemployment gap is nearly double that of white teenagers. We found 11% of the population in Nassau County speaks English less than well. That's 100,000 people. So to anyone who says Long Island doesn't have these challenges, these gaps, I think we have to start with focused on the numbers and looking at where we're at and honestly owning the fact that we have some real work to do as a region.
And I think in terms of how do we deal with it, part of it has to be, we have to look for opportunities for connection and building understanding. I always am a big proponent of engaging and interacting with people who are different than you. Because the way that Long Island was developed, right down to our elementary schools, is that depending on what neighborhood you live in, you tend to go to school with kids that look like you. So whereas census tracts may show diversity on paper, for instance, in the village of Freeport as an example where I grew up, there's a center part of town where you have the Hispanic neighborhoods, there's northeast Freeport where you have predominantly African-American neighborhood, south Freeport by the water is predominantly Caucasian. So guess what? Those kids from a very early age are going to segregated schools. So I think we need to, and I know the people in this room who are in the trenches, we need to look for opportunities to gain understanding and build bridges. Somebody brought up trust in the last panel. It's one of the things that I work on, for the police department in my current role, but as a board member here for the Health and Welfare Council, we really need to think broader. So I'm so happy about the discussion today, which is going to encompass the broader scope of where all the lack of understanding, lack of, especially with the conversation at the national level, where now people will resort to fear again because it is all the demagoguery that's happening, which is now causing people to pull back and not want to understand. And the last thing I want to say really quickly is when it comes to the media, to point out some of the statistics that you just shared with us, the images that we see of communities of color in media are negatively impacting what reality is. What reality is that people who come to this country come here to contribute, not to drain the resources of the United States. The African American community, communities of color, have long been marginalized in terms of their capacity and their labor ability because sometimes there's images that are very negative that are being reported in the news. So we need to take a look at all these things in terms of how do we deal with it. And we need to dare greatly, like I think Rebecca was saying this morning, to challenge people on their views when they say it in front of us, especially now when the national discussion has lowered the bar on civility and, quite frankly, intelligence.
Just that we have to manage things by fact. So Teresa Sanders, who's going to be up later, has this equity report that everybody should be reading and everyone should be sharing. Because I think if we're dealing with things with facts, we can get away from everyone's opinion. We we even wish people who passed on happy birthday. You know, we're wishing pets happy birthday. But when it's real data that can be shared and influenced, we're not using that power that we can. And that's what we should be.
So that's one way to try to get over the information gap. But let me ask you this. Let's get a little deeper into this. What you guys have said thus far is what I have heard. And you guys, tell me if I'm wrong. Have you heard this before? Some of the issues that are there in terms of the gap, in terms of media, in terms of resources. Have you heard this before? All right. So, let's dig a little deeper here. I'll take it as individuals. Each of you are involved with some sort of an institution. What we're really talking about here, I think, correct me if I'm wrong, is institutional change. We can all have the best intent, we can all work hard. Institutional change. How do you get your institution to change, your individual within an infrastructure? Is that impossible? Not impossible? You should have a good time. You should too, because you got your own office. How do you make the institutions accept some of the institutional responsibility of bridging this gap?
So I'm going to set up our sheriff once, because I have said this before, and I know he knows what I'm going to say. He had a form that was something I've never seen before, which I know that he will tell you about, that talked about the critical pipe. The issue, from my perspective, is that the place was packed. It was a great forum. But the people that can make the changes to the institution should have been in that room. And they were invited. Right? And they were invited. So you have to have the will, because the forum was there, the information was there. It was absolutely outstanding. So you can't change it by yourself. If it's a pipeline, you need everyone that touches the pipeline to be there. They should have been in the room, and they weren't.
What repercussions are there for?
Well, not enough. You know, you can call people out. I'm pretty good at that. But you need to have it collectively. You have to ask the tough questions, and you just got to keep at it. Like, you got to have another one. I know we will. We got to have another one. And to influence more people to be in the room. It takes too much time, but it does take time. And, you know, there are a lot of other media outlets, like yours too, that have to do a better job at covering the real stuff that goes on.
I've been here for 36 years, came to this day as the Minority Affairs reporter in the 80s. So I've been uniquely situated to kind of watch the island change. And I think, I think you're right. One of the things I always tell my peers is that the island is undergoing a change as profound now as the change after World War II, when the potato fields and everything else turned into post-war suburban housing. The browning of Long Island has impacted every quarter, including communities that were considered to be segregated. No corner, from my view, from my perspective, in 36 years has been left untouched. And it's a story that, we try to do better, but you always got to do better. And we do need to do that. So let's stick with my girl Tracy. All right.
So, what we've done, because one of my goals since I've taken office was to get to the kids before they get to me. And I feel it's so important, because that's the baseline when you look at our criminal justice system. As I just said, the amount of individuals I have in my custody that are over the age of 70, and they're not first-time offenders. So going into the schools and talking to these young men and women twice a week, different schools, to try and figure out what's going on all throughout Suffolk County. So deconstructing the prison pipeline is a second one's going to be on July 10th. All right, so you got it. So on July 10th, and really we're going to start to develop timelines. We're going to break down what we need to do. We know that 38% of the kids that are in my custody are African American, and that African Americans, I'm talking about just in Suffolk County, that African Americans make up 8% of Suffolk County. So we have a disproportionate amount of young men that are in custody, in the Suffolk County jail. And so when we look at trauma, the trauma that these young men, both African Americans and Latinos, have experienced while they're growing up is something that we're focusing on. We're looking at the negative interaction with law enforcement, with that school resource officer, because school administrators are no longer taking they're no longer handling the issues they would have handled 10 to 15 years ago, and they're pointing them off on a school resource officer. So that young child now has a negative interaction with law enforcement. And if it gets to the point where the officer says, I'm going to put cuffs on you and bring you to the station, now automatically that child's life has changed, right? They have a record whenever, or at least an arrest record, whether it's a conviction or not. But also, when they have to check that box when they're eventually going for employment, depending on where they're at in high school. So, it's a conversation that, whether anyone who is not at that forum, I believe that they're training at the station because my train is going to keep going. And I'll just keep on picking passengers at the next train station that really want to do something to really
So the fun thing about the role of controller is you have the opportunity, and in any big institution like Nassau County government, 7,000 employees, $3.4 billion annual spend, you have the opportunity in a role like controller to do a series of reports and to have a conversation and get outside of your role, get yourself in a little bit of trouble in terms of pushing issues forward. So in our first year or so, we've done that in a whole host of ways. First, when you talk about institutional change, and I think very few institutions have been more in need of change than Nassau County government. When you talk about institutional change, we launched not an audit, but a series of audits on nepotism. Why? Because you have to change what your workforce looks like and how people get their jobs, so that you have the right people in the right jobs for the right reasons. At the same time, we formed a policy and research unit to take a look at a whole host of things. The first thing we tackled is a demographic analysis, which ended up on the cover of Newsday and really highlights the issue that George was talking about in terms of the grounding of Long Island, but also makes the point from a government perspective that we can't keep doing business the same way we used to 50 years ago, delivering services to the population we had 50 years ago. We have to think about what tomorrow looks like, and the only way to do that is to start bringing people into the conversation. And that requires what is, for an organization like Nassau County government, change and difficult change, and pushing that entity forward, both in terms of who works for us, the technology we use, the openness that we have, and we have an open data portal that we launched this past year. We're going to be dramatically expanding it over the next month. I don't mean to tease next week's announcement, but that's what we're going to be doing. And we did, in our first year, a series of reports with our policy and research unit, a demographic analysis, a black equity profile, looking at veterans issues, looking at student and hunger issues. So these are things that get to who we are as an institution, who we are as a region, and start to push us forward. Because the reality that I think all of us in this room are aware of is that folks are making choices to go to other regions. And we have to update what we do as a region, what we offer as a region. And we have to start, and it's easy for us to start, and I shouldn't say it's easy, but the only place for me to start is what we offer as a government.
I think you also have to seek out opportunities within the organization for dialogue, impact, and inclusion. And the word inclusion is very important because you may have people of color or women or LGBTQ or younger people who have something to offer, have something to contribute within the organization, but they're not being included. And it brings me back to Tracy's point about the forum that you had where the administrative leadership or the policymakers in the organization for the forum that you have were solutions. I always look for opportunities to have a dialogue, to start to build. I think incremental change matters, and I think that you do start to do what the sheriff mentioned, what Errol mentioned, which is, there's certain people who are going to get on the train, there are certain people who are going to be very obstructionist, and there are going to be other people who are going to gravitate towards, you know what, I hadn't thought about it that way. And that wouldn't have happened, that aha moment would not have happened if you didn't look for that opportunity for dialogue. And then try to figure out where you could have some impact. So we run the community councils, I run the community councils for the department. It is deliberate that I'm not an officer, I'm a community-based person. So in order to build that trust, you have to be able to look for how can we really be inclusive. So we want to include the community, stakeholders. We talked about that earlier today when you're trying to craft policy or you're trying to craft systems. And often that's not the way that things work. So I think you have to be very strategic. You also have to be very strategic in terms of finding when and where the points of entry are and where you're going to have the best opportunity for someone to be receptive. But you need to push the envelope. You need to push the envelope. And the last thing is you're an education to people when you walk in the room. The way that you handle yourself, many times people assume that I was born here and I wasn't, I don't have a problem with your type of immigration, Mary Nell. You and your family, you seem like nice people. And, you came here legally and you were here, it's undocumented. It's documented people that I have a problem with. My family was here undocumented for 9 years. We were here undocumented for 9 years. I wasn't born in this country, and I'm fair-skinned. I believe very strongly in standing shoulder to shoulder with people who are darker skinned than I am. I know that I am more palatable because of my complexion than some of my other Latino brothers and sisters. So what am I going to do about that? I'm going to use it. I'm going to utilize the way that God created me to try and drive a message to get you to think about things a little bit differently.
Okay, let's go a little bit deeper. Can you think of one policy? Do you have more? That's great. One policy that your institution has put forth that helps bridge the equity gap. Because we can talk about pressuring, we can talk about influence, but when it comes down to ultimately is public policy. One policy, one ray of light from your institution.
I'm happy to start, jump in. So I think we have a variety of signs of progress in Nassau County, but I'll start with two, but they're directly related to each other. So we've taken on the issue of MWBEs, very important piece that has really been neglected in Nassau County for a long time.
Why don't you define what that is? I'm sure everybody knows what it is.
Minority Women Business Enterprise. So this is a huge piece for Nassau County. There is, speaking of gaps, there is a gap there. We put out a report on this that talks about how much more money. We're trying to phrase these things in ways that appeal not just to all of us in the room who are self-selecting and already care, but appeal to folks, honestly, that we need to convince. So we're making the argument that if you brought more folks to the table, it would make more money for everybody, and it would save more money for everybody. So the two signs of progress that I would say is, number one, we eliminated, we got together a whole group of folks, and thank you to the folks from our MWBE steering committee who are here, by the way. We eliminated the vendor fee in Nassau County, which was a really useless barrier to bringing businesses to the table. That's the first. And the second is we succeeded for the first time in 15 years in getting some consensus in Nassau County government, not easy to do a disparity study to figure out what needs to happen. This really will map the road forward for Nassau County government and how we do this stuff. And that is critical and frustrating that it hasn't happened. It's been stalled for a long time.
My understanding, my memory of the county charter reform was that a certain percentage was supposed to go to women and minorities. So they're kind of breaking their own charter here.
So unfortunately, these have only been aspirational things up to this point. But you just brought up a third sign of progress, which I was going to forget. So thank you, Joy. Helpful as always. In the construction of the new police academy. we have been successful in building in not just aspirational goals or best efforts, but real targets and things that have to be achieved in terms of bringing folks to the table and having part of that huge project. So that is progress. It's a start. There's a huge way to go, but I think that is a start in terms of bridging some of the equity gaps in terms of how Nassau County government operates.
So what happens if Nassau doesn't meet the goal? Because again, part of policy is that there are consequences. Are there any consequences here?
So we brought in a monitorship over, this is a huge project, right? And rather than just do the audits after the fact and yell and scream, which my office is perfectly capable of doing, and it's one of the things that we do well, we have a monitorship up front, meaning an outside independent monitor to make sure that these things are adhered to. And if there's not, that's a whole other conversation. But yeah, there will be consequences.
Tracy had three?
So for Habitat for Humanity, we changed the policy so that we are making sure that when we are looking for families, we are looking all of Suffolk County and not just the area of where the property that we have is. So that is a big difference, and it should open up more diversity to give people the opportunity to sign up to see if they could get that parcel.
How did it work before?
It was only marketed to the surrounding area. So if we have a piece of property in Brookhaven, it did not go beyond Brookhaven. So now we're going countywide. From an NAACP perspective, as an individual, I'm making sure in Suffolk County that I speak to all police cadets in terms of disparate treatment, bias policing, and community policing. That I hope I real talk with them about their image and do you want to be respected or do you want to be feared? One policy I would say that I didn't influence, but in my grandchildren's school district, just last week, they were home for the Muslim holiday. First time that I didn't even realize that, first of all, the state did their job, but each individual school district has to vote in order to have that holiday on the school calendar, and I think that that's not good at all, because it's now based on what the demographics are in that school district, and what I'm happy to say is in the school district where my grandchildren attend, it is predominantly non-minority, but they took a stand of inclusion and diversity, and I want to work as hard as I can to ensure that every school district does the same thing, because it's on the state calendar. There's no reason why we should not be celebrating everyone in Suffolk County and on Long Island. So that's not a policy that's changed, but that's a policy that we need to work on.
Unfortunately, with a law enforcement perspective, especially those that are incarcerated, what we are trying to do is show more respect to the men and women that are incarcerated and also their visitors. Because at times, individuals that come and visit a person that's incarcerated feels like they are also incarcerated. And so it's been my goal, especially when I worked on Rikers Island for 25 years before being sheriff, and I saw some pretty horrific things with individuals coming to visit men and women who are incarcerated. And so it's very important for me that we show respect to every individual that's incarcerated. So I say 80% of the men and women that are in our jail are going to be individuals that are in front of you or behind you at Target, seated next to you in a movie theater. They're going to return into our community, and we really need to extend a helping hand and show them respect. The other 20%, unfortunately, no one wants them because they're going to be harmful to all of us. So that's very important to me. The programs, the rehabilitative programs that we're working on where we have Choose to Thrive for our female population to really try and help them empower their lives and regain their control. Choose Your Path for our 18 to 25-year-olds, where we're actually introducing small engine repair, carpentry skills, and also landscaping. Skills that are transferable, so when they leave and transition back into the community, they can possibly, hopefully, gain some employment. We're working with our veterans. Fortunately, since I've taken office, and has nothing to do with me, our veterans pod census has dramatically reduced. Now, some have said that there are many men that are not admitting to being in the military, and maybe they have other issues due to classification, so we can't put them there, but we have had a drop in our veterans pod. And then also, as I said earlier, our senior pod, where we're trying to address the issues of an older population who are incarcerated, reconnecting them with their families, possible employment when they transition back to the community. You know, they can commiserate with men who are of their same era. And so, you know, with that, how are we going to better serve the men and women who are incarcerated? Because they all have gone through trauma. As I talk to a 70-year-old or I talk to an 18-year-old, they all have gone through something traumatic in their lives, and it's caused them to become incarcerated or caused them to make poor choices, mental health issues, or substance abuse issues.
Speaking specifically about the Nassau County Police Department, where I currently work, one of the things that we've worked on is called the Commissioner's Community Council. My role in the department is new. I've been on for almost a year and a half now, and it basically created an Office of Community Engagement at the Commissioner's office level. So what does that do? It gives people access. You don't have to rely on the person who picked up the phone when you need service, not a 911 call. I'm talking about an issue with the precinct, that there's something that's going on in the community. It gives them access to resources that we have. PAL, information about programs that you want in your school district on prevention, which is a big piece of what I do. The Too Good for Drugs program, the GREAT program, which is gang retention resistance program, gang resistance training and program for staff and administrators. Bringing kids into the police department, kids of color, to take a look at this as a wonderful career, because the other thing is we need to be able to be a part of the structure in order to change the structure, right? We are really dignified by one of the most stellar police officers that we have, which happens to be our chief of police. He's the first African-American chief of police. His name is Chief Steve Palmer. He rose through the ranks of every single command and precinct because of his excellent work. Most people don't know that he's the chief of our police department. That's exactly the way he likes it, because he likes to focus on the work. But when you focus on the work, you do rise up in the ranks. So the Commissioner's Community Council allows regular community people, there's about 240 of them now across all 19 legislative districts, to have direct access on any issue, whether it's an enforcement issue, whether it's an issue of wanting to have dialogue on disparity or concerns in their community, or they want training on vaping or dating violence or suicide prevention, things that you wouldn't think a police department would do, well, we do it. And we just want you to call us, and we're going to be able to come into your school district, your civic, your house of worship. So it gives people access at the top. And what it does is it eliminates a barrier, which is also very important, eliminating barriers within organizations, so that you don't have to rely on, oh, you called the second precinct and the person who happened to pick up the phone, maybe that's not their lens, right? Or it's not their, what they're passionate about. Well, when it goes straight to the commissioner's office, it's assigned, it's tracked, we have data, we have to report back, we get results, and then we're able to build from there. So, it's something that's a model that we're very, very proud of, that we're working on. It's still a work in progress. So I think that that's one of the major things. And the other things is really capitalizing on the talent that we have when it comes to women and diversity. Giving them opportunities to share their experience and to share. And when I talk about their experience, I'm talking about diversity of thought and experience, because that gives you a competitive edge as an organization. So when we see that and we see talent, for instance, what I do as one of the assistant commissioners, I make sure that I highlight when we have a woman in a command who is doing an excellent job, who's gone overlooked, or, you know, a person of color or someone who speaks another language, to give them opportunities to share their experience, to present, and to lead, not just to support. Not just to support at the bottom, but to lead, because they have the capacity to do it, they just don't have access.
So we've heard four very different groups, and in a room of multiple groups. How do you all work together? Because what you're basically talking about is a common cause. How do you get out of your areas and work together to get to this equity question on Long Island?
I think one of the best things is the fact that there's leadership on Long Island, and there's community-based organizations. You know, since Rebecca has taken over, and not only because she's a friend, I think she's done a fabulous job, not only helping. You know, what she does for the community, but what she does for those vulnerable populations on Long Island, especially those that are incarcerated. Her and I have been talking about a community corrections model that I want to create sometime next year, because we know when an individual leaves our custody in Yaphank or Riverhead, they're just left out there. You know, they're given their property, and then they have to fend for themselves. Transportation on Long Island is horrible for these individuals. I had no bus routes for any individual leaving my custody in Riverhead or in Yaphank. And so we were able to at least get 3 bus runs. So think about it. If you get released from jail, how are you going to get home? How are you going to get from Riverhead to Babylon? You know, and then what are the services that are in Babylon that you can go to for healthcare, for employment, for housing? And so this community corrections model will be a group that can follow the person, if they want to be followed down. Because not everybody wants assistance. But if they do want assistance, once they leave our custody, they have someone that can directly connect them to the various resources, not only in their community, but also in the county. So that is a goal. And then that continues working with conversations and people that are really engaged. Because, you know, you have some people that come to a meeting because they have to come to a meeting, they take their notes, they're on their cell phone, and then you have the people that really want to be problem solvers and say, how do we help? What can we do? These are the services I have to offer.
I'm happy to jump in and say, so this is something that we have been looking to do a little bit in the Controller's Office, get out of our comfort zone, get out of our silo, so to speak, and as the numbers folks. So as part of our research and policy unit and our engagement effort, shout out to our folks who are here, by the way, sitting at the center table there with the comterns. Yes, we call them comterns. So many controlling puns to me. So, still a little time, right? So what we've done is we've gone out we've had these conversations. We're taking our reports on the road and trying to use them not just to be a report that sits on the shelf, but be more of a dynamic entity that facilitates conversation, that goes places. And there's another piece of that that hasn't really clicked in yet. And Long Island is prone to a lot of inertia, but there's a lot of folks in the room that we have collaborated with. So I'll throw this out today, which is to say, you know, if there's an issue you want us to look at, if there's data that you have that you think that we can use, and something that we can partner on, whether you're an individual or an organization, and Rebecca is probably the lead leader here, you know, come talk to us, and this is what we want to be doing. And it's the only way that we can get sort of the word out, and our worst fear is that we put these reports out and nobody knows.
I would suggest that we all work together. The challenge is that there's not enough. We need to get more people. The other thing is we have to do a better job of making sure that the information that we get from these powerful sessions are disseminated to people that are not here. So, for example, if you're here representing a hospital, are you taking that information back and getting all this information to the policymakers, or are you just here representing the hospital? That's an example. So I think we
and you have to look for opportunities to collaborate within the organization that you work, and also externally. For instance, this stellar panel of professionals here, I know them all. I work with a lot of people in this room, and it's not my job, it's not my role. I try to find the hat that I can put on without getting myself into too much trouble, so that it can be part of my job, right? And taking a multidisciplinary approach to what you do. For instance, just to talk about the police department, how many 911 calls? If there were more collaboration with the Department of Social Services, with the Department of Health, with the Department of Mental Health, where people were really getting the care that they need, wouldn't end up in a 911 call for somebody who's, thinking of committing suicide, somebody who's homeless, somebody who's mentally ill, somebody who's addicted, somebody who's just agitated because they're cold and they're hungry. And, when I'm cold and hungry, I get pretty cranky too. Right? So I think that collaboration is something that we need to seek out as professionals, and if we don't have the resources within our structure, we have to look externally. The challenge is that when you're not the head of the office in charge, you also, very important, have to be very, very respectful of the protocols that are in place. You have to be very respectful of pitching an idea, persevering, maybe they don't bite the first time or bite the second time. Incremental change matters. So you try you try to also find like-minded individuals who are willing to take on some of the burden to get this to come to fruition. And I feel that that's a very successful strategy that will work when you feel like you're the lone voice, or there are other voices who are a little more shy about coming forward. And then the last thing is support one another in your weaknesses professionally. Everybody is good at something, not good at everything. So if I see somebody who's talented at something, and they can strengthen what I'm doing and vice versa, hey, let me help you with that. What do you need with it? I have no idea I don't know the difference between a sergeant and a lieutenant. And I actually asked my first day on the job, I asked one of the cop officers, how do you figure out, like I'm good with names, but how do you figure out the lieutenant and the sergeant and the and he sent me a cheat sheet. He called it a cheat sheet. This is what we used to use in the academy, he said to me. If it's a chief, scrambled eggs, that's what we used to call it. You see the chevron, that's a sergeant. So that I could show a sign of respect to people for the rank that they earned, right? As a civilian, as somebody who's coming in, it's part of my job too, to learn the culture that I'm going to be working with, and that shows respect. And when you do that with people, it's just like when they come into your office. If they speak another language, it's not going to kill you to learn how to say something in another language. I try to learn it in as many languages as I can. And it allows people to open up and to try to work with you, to try to meet you in the middle. So I think we all can take that approach, and all of that starts to build on building that trust that we've been talking about.
And speaking of opening up, now it's your turn. You got any questions for these folks up here? I would take advantage if I were you. What's on your mind when you hear about some of these things? We're trying to get sort of beyond,
Hi.
There. What am I right way over there?
Hi, Stephanie.
Let's stand up so people can you just tell us your first name and the organization you're with?
Stephanie. My question, I guess, was more towards like police officers and police staff. Is there any policies or any method that the civilians have in order to see what kind of officer they are, if they've had any incidents with the public or with those who are incarcerated, or even those who are visiting? Is there any way for us to see if they've had any incidents, or if that was being unfair, or if they were just? Or is there any way for us to see something measurable in some way that we can track our officers to see if they're being held accountable for the things that are going on?
Ooh, that's a good question.
So, as far as accountability is concerned, it really lies at the head of the organization. And so within the organization, there's an Internal Affairs Bureau. There's obviously clearly different rank structures regarding any investigation of any inappropriate conduct or misconduct that might be going on. So, with law enforcement, like the military, most law enforcement are paramilitary, really have their own investigative bodies internally. Of course, if it's of criminal nature, then it will go outside to a district attorney's office, for further investigation or possible criminal charges. So you know, are you asking, like, does an officer have excessive uses of force? Is that information accessible?
How can we know for sure that this officer, we're supposed to inherently trust them, but for a teenager, it's easier to trust someone that has shown years of experience without any incidents towards their demographic, you know?
You know, so, you know, most law enforcement agencies try to put the appropriate staff in appropriate areas. You know, for me, it's a matter of having maybe prior social workers or teachers that now work with our young adults, or you know, those that have worked with, as far as counselors with women previously, that now work with our, you know, women's pod. You know, we have correction officers and sergeants who are prior military that work in our veterans pod. And so it's really trying to put the appropriate staff. And it's incumbent upon the leader of the organization to have a finger of the pulse. The one thing I like to do, and believe it or not, I like to walk around my jail. I like to talk to inmates. I like to talk to the officers. I like to find out what's going on. If an inmate has a complaint, believe me, I've heard them all for 27 years. I know which are the legitimate ones, whether it's mail, whether it's visiting, whether it's phone calls, or whether it's something serious because an officer's keeping them locked in. And you can really tell. And you can also tell by the amount of complaints that you get. You know, so each one that I get, they will be investigated. I do try to talk to the inmates. They do know who Sheriff Toulon is. And so I think that's the most important thing for the leader of the organization to get involved in the community, get involved with the organization that they work with, and really let people know that they're there, they care, and they will not take any crap.
The other thing, and I'll piggyback on what the sheriff said, you know, no one is above the law, period. That includes every police officer. In Nassau County, we have a very, very, very high standard as to what that means. I can't speak to other police departments. We never have agreed to come and work in an organization that didn't have it. There is a complaint process in place. Any constituent can file a complaint against any officer at any time. So it doesn't just stay internally in terms of an investigation. Those complaints are tracked, they're investigated thoroughly, including the same with external complaints like bias crimes and different things. I think what people need to do is not stay silent and follow through. You know, sometimes we get caught up in emotion, and this happened to my neighbor, or XYZ happened. The Commissioners Community Council is another avenue. When we hear of, listen, you know, there were 2 officers that came to the park and they spent time, they stopped, they played ball with the guys, and you know what? We hadn't seen that in a long time. Thank you. Or, you know what? How come nobody comes by? Whatever the issue is, you have a direct line now to the Commissioner's office, but there's always a tracking system for these complaints that then go to internal affairs. And lastly, it's really, really important, I think, for people's concerns to be validated and documented. So we really pride ourselves on making sure that we track that. And I just want to put in one plug for our police commissioner, which is the first thing that he says in any recruit, where they're getting sworn in, and I used to do training for the Department of Cultural Competency way back when, 22 years ago, is I want an officer that can control his or her emotions. And our goal in this department is de-escalation, de-escalation, de-escalation. And any officer that is not following that and properly following our policies on use of force will be written up. My goal is going to be to try and get you out, and it's going to be tracked. It will not be tolerated.
The answer to your question is no. You will not be able to pull to find out if there is a history of any type of any sort. That does not happen. Nor do I think it should, but I'm just saying that that vehicle is not there. You know, I am the daughter of a police officer, proud. I will say that we just heard or saw the case about Mr. Bush, who was incarcerated, prosecuted wrongly. Those types of things, I'm sure that if you go back in the officer's history and in the ADA's history, the signs were there. So we absolutely have a lot of work to do. The sad It's a very small amount that tarnishes excellent police work, excellent corrections work. So we have to do everything that we can to rid that small amount of people out of the force.
We've got about 5 more minutes left. Sir?
Yeah. Good afternoon, everyone. Thanks for turning up. I really appreciate it. My name is David Sinclair. I work for the Union in Hempstead. And I think the state of equity in Long Island is such an interesting question because to me it boils down to 3 things. It's housing, it's transportation, and it's education. I'd love to know from the panel if they could change one mechanism in how we operate Long Island that could have the biggest impact on what they do. And I'll throw one out for you. Everybody that is on DSS gets free transportation. It's happening in other counties. They already have time poverty in terms of getting from place to place. The buses are primarily empty. And we spend a lot of time handing out Metro cards. You know, let's do something that probably does not cost something, or do some analysis and see if we can give all of these folks free transportation. That would be my idea. And I'd love to hear the panels, what one piece of policy would they change or structure in terms of the island? Thank you.
So, education. Education is the foundation to every child's future anywhere. And we all know in this room that depending on the zip code that you're born into, that's going to impact your entire life. So the inequity that exists in education on Long Island is criminal. It really is. So if we could do, if there was one thing that I would want to see change first, it's that. And, getting mediocre people out of the districts that are in charge of making the decisions about the children. And that's the problem, because it becomes this perpetuation of being so desensitized and feeling that there's just no other hope for these kids, right? And so I think that would be the number one thing. All the other things I think will follow if we talk. That's just my opinion.
So I'll start by saying I agree with everything Marianella just said, and I'll build on it. I'll give you 2 quick things, and they're not quick, but I'll do the quick version of them. The first is public transportation and infrastructure. And you think about it, we were built as a region a long time ago. We are the oldest suburb now in Nassau County, and other regions are getting ahead of us. So what do we not have? We do not have, we are built to get us from wherever we are on Long Island into New York City. That's the way our public transportation works. We are not able, and it is a tremendous economic loss and an equity piece, we are not able to get north to south. If you live in Nassau County, if you live in Great Neck, you have no way to get to the hub, and no way to get from the hub to the beach, and vice versa. And that would be a dramatic game changer. People say that we can't afford that. And it's one of those things that we talk about all the time, but I would throw out the idea of how much it costs for us to do nothing. What it costs for us to do nothing is young people leaving, right? Is all of the economic losses that we talk about, the $24 billion racial disparity gap that we have economically. Think of how much more that would put into our economy, how much economic activity that would create, right? So while some of these things are scary and only government can get involved in them, and we say we can't afford it, we also can't afford not to start looking at these things. So that's the first thing. I guess it's not all that quick. The second thing that I would mention, and we can't leave this panel without mentioning the census. Why? This is how we get our fair share. Long Island gets $675 billion in federal funding every year. If you look at the top 16 things that it funds, it's everything. It's all the stuff, right? Think about, one of the things being talked about is Medicaid today. This is where the disparities are. So, if we are counted, and we are hard to count, and if we are counted correctly, we will get our fair share. And if we get our fair share, that will bridge some of the inequities. And if we get our fair share, we will get the kind of representation that we need at the federal level. And if we get that kind of representation, then we can end this sort of gerrymandering and make sure that we are actually represented.
I would say education. When I look at the young men and women who are incarcerated, I feel education is the key to really avoid them being in the criminal justice system. As I said to you earlier, and I'm going to be very quick, Joy, I've been in 1 and 2 schools per week since I've taken office, and when I walk into certain school districts or certain schools, and I see an overflow of students in the hallway with teachers working, and I go to another school district, there's only one teacher with about 15 to 18 students with a nice whiteboard and better technology and better school books and better resources. Clearly, there's an issue in Suffolk County with our schools.
I live in housing and food, right? It's the stigma of affordable housing, the availability of affordable housing, the cost of affordable housing, and the realization there are a lot of children and adults can't eat every day.
And with that, I want to thank you for your attention. I'm still going to sleep. That's always a bonus, especially after a meal. And tell you that you're getting a 3-minute break. Do you want to come back up? Or? I'm sorry. You get a 2-minute break, and then we go on over to the next panel. Thank you to the panel. Thank you for your attention.
We're going to get started. If anybody would like to take a seat, please. Okay, we're ready. Good. I'm Lori Andrade. I'm the Chief Operations Officer for Health and Welfare Council of Long Island, and I'm so pleased to be here today, this afternoon, with you for the last panel of the day. We've had a great day so far, I think, and we started the day out being really inspired by Rebecca reminding us of some of the challenges we have on Long Island, asking us to dare greatly. We followed by the keynote speaker, which gave us a very big vision for us to think about and for us to aspire to. And certainly I know I had some systems envy this morning, but I think we have a vision there that we can all reach towards, and that's important for us to have in our minds as we continue to do this work. Our first panel spoke to us about our Healy members, and we heard from them that they're ready. We are ready. We are ready to do this work. We've been doing this work. We want more people to do this work with us, and we are ready to continue. Then we had our lunch panel just now, which, hearing from our regional leaders about the challenges, but also they are really committed to doing this work with us, was very inspirational and important. And some of the things that I heard were, the sheriff saying the train is going to continue. He'll meet us at the next stop. We all need to be at the next stop with him. And also Marinella talking about incremental change matters. And it does matter. And this panel is really going to be about that. What's the incremental change that we can take together? What are the things that are going on around the nation, the region, the state, that we can take that incremental change? So I'm really happy to have us here today for National Innovation of Writing Future for Long Island. With me here is Teresa Sanders, President and CEO of Urban League of Long Island. We have Steve Strauss, Head of Network Development for Unite Us. We have Brianna Brennan, Senior Director, Performance and Data Strategy, Alliance for Better Health. And Shoshana Brown, CEO of AIR NYC. I'm going to ask you, each of you, just to start out by briefly describing your organizations and the role that you play in either Medicaid transformation and or promoting equity.
Sure. Teresa Sanders, as she stated, and I have been doing this work on Long Island for over 30 years now. And Long Island has been a very interesting place to work. So at first when I was asked to be on this panel, I was like, why this panel? I was in my comfort zone with the last panel, but then I started thinking about I need to step out because one of the challenges we have as being a suburban model for equity is that it doesn't exist. And so we have been fortunate through the Urban League work to partner with some national models and to be able to help design the very first suburban equity model that we hope to be able to take on the road.
Hi, Steve Strauss from Unite Us. So Unite Us is a care coordination solution.
that connects folks comprehensively to health, human, and social services, to make sure that all of their needs are being met, to make sure that comprehensively we can track people throughout their total care journey, whether it's in the hospital or primary care, whether it's at a transportation organization or a housing shelter, and to make sure that we're collecting real data throughout that process and making sure that folks never fall through the cracks. So increasingly we're working in this social determinants of health space to bridge the gap between organizations, to bridge the gap between sectors, and most importantly to create what we call networks, real networks of care where we're onboarding organizations throughout the care continuum and approaching this work which even this language around social determinants of health is very healthcare centric. Wow, it's right there in the name. But onboarding organizations to give community-based organizations, public agencies, behavioral health works, to give everybody credit for the work that they're doing, and to set up these accountable structures that can really improve a lot of work. So I look forward to filling in you guys more. I work on the network development side, which is what it says, right? Setting up these coordinated systems. And we've done this about 50 times in 30 different states, so I look forward to sharing some of those successes.
Good afternoon, I'm Brianna Brennan. I work for the Alliance for Better Health in the capital of New York State. And I think what's important first is actually the name of my organization is the Alliance for Better Health, originally the Alliance for Better Health Care. We struck off the care part because my CEO is very passionate about health not being specifically health care, and that it's really all about upstream. I am in an interesting part in my career, both in the role that I play in my organization, but also in our organization's journey to what it was and what it will be. And we are an organization that was really originally born through the Medication Redesign Initiative, the 1115 waiver that we all call DSRIP because we learned that acronym today, and it rolls off the tongue. So we do not have a hospital as a foundation. We actually are a collaborative of 50 different providers throughout the community, both healthcare systems and all social service organizations. And it's from that journey that we took in DSRIP that we decided to become an independent provider association, which is an acronym called IPA for short. And technically that means that we have a business model after the DSRIP program is over in 2020. And why that's important is that our organization is true to what we believe is the linchpin of healthcare in our community. So our independent provider association is formed by all community-based organizations, so all health and human service agencies. These are folks that are the Tier 1 CBOs or the non-billing entities who survive through grant funding and philanthropy, all the way through the Tier 3 CBOs who receive some monies from Medicaid, like the community organizations, clinics, and such. So we are new in our journey as an IPA. We are going to carry the name, and our mission is health equity.
Thank you. I'm Shoshana Brown, CEO of AIR NYC. The AIR stands for At Home Intervention and Relief. But when the organization that is now AIR NYC started in 2001, it was a participatory-based research initiative in Harlem, formed by the legendary Jeff Canada and Columbia operated Harlem Hospital, who recognized that asthma was the #1 reason children were missing school and the #1 reason they were hospitalized in Harlem. That's still true in Harlem, it's still true in New York City, it's still true in most of the country. So I've been leading the organization for 10 years. We got our kind of foundation in asthma, but we now have evolved the model to do home-based community health worker delivered care for vulnerable families who are struggling to manage chronic diseases. And we've also added an aging in place component onto that. But at the core is really addressing the social determinants of health, and we were doing that before it was a thing. I got into this work personally as a community health worker in Burkina Faso, West Africa in 1995 when I was doing home visits myself in a village without water or electricity, and really kind of learning firsthand in extreme poverty how food insecurity, housing instability, all of these things, having to ride a bicycle 25 kilometers to get to the closest healthcare facility, which would have been staffed by a village-trained midwife at best. So in that context, I learned, and there are lots of lessons that I've been trying to bring to the work that we do in New York City. We were around before Disrupt, and I think we'll be around after Disrupt because there's still no health equity. And it's great that you guys are solving and making sure that, Steve, that everybody's getting care. I would argue with the potential for us to actually source that care beyond, making a referral. A referral to the right social service provider is certainly the first step. But one of the challenges, which I think we're going to talk about on the panel, is we can refer all day long. We don't have housing in New York for people. We don't have food that's nutritious and sufficient for people. And so we have a problem, as you all know, and I'm preaching to the choir. But in Air NYC, we're kind of trying to tackle it on the ground, boots on the ground, one day at a time, one home visit at a time. Our community health workers are amazing. Yes, they use technology, but what it's really about is connecting in the appropriate language with cultural humility with families who are struggling with a whole lot of things.
Thank you. Steve, I'm going to start with you, asking you, we're looking at incremental change, right? So some of the issues are really large, as Shoshana was just saying, and it is, one day at a time. So looking at incremental change, looking at best practices and models around creation, around the nation, which is part of what you've been doing. What suggestions do you have? What has your organization done and other organizations? What's our best practices?
Yeah, that's a huge question. But just to dive in and get started, it helps to have a national community of practice. And so, again, having set up these 50 coordinated systems touching, I think, 30 states now, we know that depending on the geography, depending on the politics, depending on the population and the demographics, that the approach has to be flexible. So setting up the tools that can be flexible, that can be configurable, that can be rolled out in a way to serve that population best, and having the experience to understand how that's going to work in communities. So if a health plan is taking the lead, we know that there are certain needs that they're going to have. If it's a health system, if it's a government agency, if it's coming from the community side, it's going to necessitate different things. The most important thing that I can say that's universal is actually a repeat of something I think Alex said in the morning session, which is that technology is the easy. You can set up infrastructure that allows organizations to refer to each other, to give you visibility into someone's care across organizations, across sectors, to do all these things to capture that real data. And I'm probably going to go on and on about data in some later question because I'm a tech lead and that's what we do. But actually getting organizations to work together, getting everybody on the same page, setting up a curriculum that allows every organization, every person to have a voice, including and most especially the population that's being served, is the trickiest one. And there's no real way around it. So actually what I would describe as the change management process is always going to be the trickiest thing. And having the tools in place that recognize that everybody needs to be heard, that everybody's sort of consent and everybody's best thinking has to go into a formal infrastructure across a geography, whether it's a city, a county, a region, an island, or a state. You have to have that curriculum in place, and it has to be flexible enough to accommodate whoever you're working with and to better understand or best understand their importance.
Great points. I think we heard this morning that there is a coalition in place. Healing is a coalition of like-minded people wanting to move this forward. And I think we heard from Bill that there is a national movement going on as well, where there are some that sharing the best practices and the tools. So I think we're positioned well. We'd like to add some, either from the state perspective or local perspective.
One of the challenges I think that we have as community-based organizations is that we are so locally focused sometimes that we think this is all our problem to solve. And we don't look out for other best practices that can be implemented. And I think that was one of the most eye-opening things that we've gone through as a community-based organization that serves Nassau and Suffolk was to get on a platform with other national organizations. So we became part of what's called All in Cities. And this is an initiative led by policy work. So we're looking at how do we create leadership models, because we can't do all the work, but how do we create this leadership ecosystem where people use their own individual organizational best practices, but then partner with each other to solve some of these larger issues, because it is impossible to solve them on your own. You know, we serve below, 3 million people on Long Island. Impossible. Our transportation systems don't allow us to connect. So we must deal with each other, and that's the model that's helped us kind of move the agenda forward.
And Confronting certainly is a really important national partner for a lot of those. And I think the fact that you brought them here to help inform them about suburban equity issues is really important, because that's not necessarily always the focus across the nation. What are the unique pieces of suburban equity and segregation? So thank you for that. Continuing, what has been some of the impact you had in improving equity and access for your communities and families? Do you want to take that, Shoshana?
Sure. I think it's hard to say that we've improved equity, but access. You're right. I can speak about access. I think we exist because there's inequity, and there isn't a single Caucasian family in our organization in terms of like who we serve. So it's all, the people we serve are, everybody's living at or below the poverty line. Everybody's struggling because they're referred to us for a chronic disease. Like they're literally struggling to breathe when they have asthma. They have, walls crumbling and rodent and roach infested homes. They have landlords who don't address those things. Speaking about the case of like an asthma referral. What we do to try to improve access is to try to first meet them where they are in their homes and come up with a plan together, a customized plan to tackle each one of those triggers in the home environment. Meanwhile, we're trying to work with people to better understand medications, so there could be better adherence. And when you have health literacy challenges, it can be difficult. We find that that's one of the things our community health workers spend the most time on is doing the education that gets lost in a care transition from a healthcare facility to home or to the community. And linking people to care. Whether it's healthcare or food pantries or workforce development programs, helping them access benefits that they may not know they're eligible for. Again, just sort of one family at a time.
Thank you. Brianna, do you want to comment on this? What are some of the best practices that you've all looked at?
Thanks. I think I'll start with a story. And we had a gentleman in a patient, a client, a human, who showed up in the emergency department, and he had been there a number of times and over the course of a month. And the emergency room navigator kind of pulled him aside and asked what was going on. And he said, well, I have uncontrolled diabetes, but I wouldn't normally be here, but I lost my Medicaid, and so I'm no longer enrolled, and really this is the only place that I have to go for care. And that community navigator was lucky enough to have been trained and member of our bi-directional referral system called Healthy Together, powered by UNS. That particular member was referred to one of our community providers who does health coaching and enrollment and linkages, and within 24 hours was back enrolled with Medicaid and had an appointment to a primary care provider who then was able to be re-engaged with his medication management and access to the appropriate level of care at the right time. And I think that's an important story because it's the power of what having an opportunity to connect folks holistically at the right point, at the right time, with the right care. It also is a very valuable statement from a payer perspective, right? So I sit in this kind of unique role, which is providers and payers, and I can take that and bring that back to the managed care organizations to prove the value statement of having community organizations in a connected environment to be able to serve and deliver care at the right time. So that's one of the very tangible things that we've done in the community. One of the other really nice things that we've been able to do is fail fast, fail often, but we're a convener, and we bring both our providers from the clinical and non-clinical setting together with folks with lived experiences, and we elicit the feedback from all of those parties, and what we hear and what they say, what our committees say, and then what we learn are oftentimes not exactly the same thing, right? So some of the things that they're saying is, well, we don't have services, but what we're really learning is they just don't know each other exist, right? So having the opportunity to convene organizations and hear where the pain points are, we're also able to a lot of times flesh out some of these services that we don't need to recreate the wheel or reinvest in things, we just need to connect people together.
Sounds like you guys are taking a pretty unique role as a health system.
Yeah, we've found ourselves in a really kind of interesting place where we can be entrepreneurial, kind of, and break some of the molds. One of the other systems that we have in play in our area is a thing called circulation. And circulation is an Uber for non-medical transportation for Medicaid recipients. And so they are able to get transportation to things like the grocery store, to the laundromat, to the pharmacy, and that we have found to be really valuable. There was some media coverage recently on a guy who was really excited about his experience with circulation because the Uber drivers, not only did they treat him respectfully, which was the first point that he made, he was also able to successfully go to all of his meetings and be really active in his journey through recovery. So that's another one of the tools, and I think those are technology, and technology are tools, but they're not solutions. All of our service providers are really the ones who are driving the change in our region, and we have some community and home-based interventions that we have that are really, really turning people's experiences in healthcare on their head. It's my job in the future to be able to package that and figure out how to sell that to a managed care organization. And then we can fund the continued efforts of our community organizations.
The health system is packaging it, but for your
So, yes, exactly. Us as an independent provider agency can serve as we serve as a master services organization. So we provide some of the things like HR and legal and compliance and audit and data analytics. So some of those foundational things that cost a lot of money, and not everybody's really good at it. We're super good at it. What we're really not good at is touching people, but our providers are really good at touching people. So we kind of come in as a collective force, and that's what we see as being sort of the driver of change in our area.
Wonderful. So, I mean, you've described a lot of kind of key pieces that have played a role in your success related to systems, technology, relationships. What about the rest of you? What has been in place that's played a role in success in terms of either systems, technology, or kind of unique partnerships, or what hasn't and you need?
I think, building this, what I heard is this ecosystem. And building that is a challenge. And one of the things out here is relationship. Because what will make us successful in terms of building a more equitable region is you have to have buy-in. You can't do it on your own. So part of the struggle and part of the benefit is because I am sort of a dinosaur out here on Long Island, and I know just about everybody, or at least been in the room with just about everybody. Having that initial conversation in areas where people are uncomfortable, particularly when you start talking about race equity. In our space, we're talking about racial equity. And people, all of a sudden, as soon as you bring up race, go on the offense. I'm not racist. I have black friends, and they say all of these things. Like I didn't say anything else. All I said is let's talk about race equity. And then once you get past that barrier, you can start having real dialogue about what the experiences are and how we can fix them. It was brought up earlier about the women in healthcare, and when you talk about, immediately when you talk about race, the conversation shifts to poverty. I said, we live in Long Island. We've got black folks that live in places that has nothing to do with poverty. How are we going to solve that racial issue for them if they go to the hospital and the care is so different that they're dying at twice the rate? That is still a racial disparity issue. When you start to have that kind of dialogue, you then get people to have a different kind of a conversation about how we solve some of these issues. It becomes civil. They're not afraid to talk about race. Sometimes they're like, I never knew that was happening. I thought everybody, if you had money, you're good. No, not like that. And when you have a model that's based on one group, so if you have a good model based on one group, that's transferable to the LGBT community, it's transferable to women, but we've got to start building these models of equity and not be afraid to talk about racial equity.
Yeah, I would just actually build on that a little bit. I mean, one thing that I hear all the time, whether we're in Utah or Connecticut or North Carolina, Oregon or New York, is that service provision is fragmented. Everybody's in their own silos. I think that's true to an extent, but just Lori, to answer your question about structure, there are some structures. There are gatherings in target areas around common needs. And I think, again, one thing that I always push back on in healthcare specifically, whether we're talking Medicaid or talking health equity or talking provision of care across the board, is that the social determinants of health are the same as the social determinants of educational success in a team, the same social determinants of reducing interpersonal violence, the same social determinants of enabling upward mobility, the same social determinants of slowing or eliminating the carceral revolving door, which came up a lot in the last panel. And there are affinity groups, there are gatherings, there are allied groups, folks in these fields, in the sectors, in policy areas, know each other and are working towards common goals. The trick here is to build on that, those sort of nascent structures, right? How do we take that to the next level in a way that is comprehensive? Because those same services, the same services that, Shoshana, as you mentioned, are 100% lacking in a lot of cities and counties and regions, or certainly there's not enough of them. Those same services, those same service providers are serving a lot of the same things. And so what we've seen, and I think North Carolina is a really cool model here, is that state's Department of Human Services stepped up and said, we want to onboard thousands of community-based organizations across the state. We're going to onboard the large health systems, the primary care groups, we're going to onboard the managed care organizations. And by the way, they're going to pick up some of the tab for this because they're going to benefit from it more than anybody else if we're keeping people healthier. So setting up a comprehensive infrastructure, building on, but I do see some structure there, but it's sort of sector-based, and I think it can be.
So I agree that, yes, it's the same social, we're talking about the same social determinants for all of these different sort of outcomes. I think one of the reasons we tether to health is because there's a payer, right? We have health insurance companies, we have health systems. And to the extent that we can make the case and the value proposition that we're all trying to do, to say, well, we can reduce, as district trying to do, we can reduce avoidable admissions, we can save money for the insurance companies. I mean, it's payment reform that's driving the openness to even talk about social determinants, which to me is kind of mind-boggling, or not even kind of, just it is mind-boggling that it took payment reform to have people paying attention to social justice, to have you, Unite Us, be able to raise $65 million from venture capital. I mean, on one hand, that's amazing. On the other hand, it's pathetic. I'm being recorded, so I have to be careful. I mean, I'm very excited about interest from the private market into the space. And I think we should all figure out how to ride that and make it work for whatever causes we're working on, whether it's mass incarceration, whether it's whatever kind of substance use disorder, all of the issues that we know connect and have race as at the heart. Race and class, I would say. I mean, there are probably a few others. But, I think the tethering to healthcare is because there is a way to get it paid for. And that's what's different about this conversation now. None of these terms are new. None of this awareness is new to those of us dinosaurs in the room. It's that now there's a market-oriented interest. And I think that's huge, and it's also, let's be honest about what's driving this and figure out how to make it work for the social justice, environmental justice, and race and equity and all the causes we really care about.
Just push back a little bit and say there might be a way to pay for it. We're not altogether sure that there's definitely a way to pay for it through this Medicaid transformation. So how have Medicaid transformation supported your work, and how has it been?
Well, I'm here because of Medicaid transformation dollars.
We all are.
Well, one of the things, and I think it just sort of is a nice organic segue to what you were saying before, is when New York State took a step back and realized that there wasn't going to continually be this funding mechanism to grow at the rate the costs of delivering the care were going to grow, part of that funding transformation, or that revamping of the funding mechanism stopped, and what we did for the first time was look outside of ourselves and say, where else are people doing it and doing it better and doing it differently? And when we look over to across the sea to the UK, we see that, and this goes to somebody else's point they made earlier in the day, that those systems were funding more into their health and human services, and their health care outcomes were better. So in that light, I like to think that DSRIP was well-intended. And I'm a DSRIP roadie because I'm on it for the long haul. I actually sat with the state for the first 4 years of the program until I transferred over to the Alliance. And I know firsthand why some of the decisions were made. And then I also understand technically how those decisions created challenges in this transformation effort. But the technical failures, I think, are there, and they were, and it's an opportunity to learn, but there's opportunities that came from that as well. And when I see, so through funding, I see two different opportunities or pathways for us. One is that the Department of Health recently added in some language, one very simple sentence into the value-based purchasing roadmap, which essentially allows for managed care organizations to fund non-medical services under the same fee structure that they pay for medical services. So, flashback to current state, they can only allocate 15% of their funding for non-medical services, and those are the services that everybody in this room provide. And that's usually where philanthropy came in, and it was kind of like a pat on the back, and here's a small check to do something in your community. But now we have the opportunity a bigger door is opened, where we all can participate in sort of having the same share of the pie. And the second is, and this is more of like a moonshot and a pipe dream for myself than something that I've actually seen in New York, is social investing. Because even as we continue to deliver these services, there will still be a payment gap. There is a requirement, I believe, that we have an alternative payment model, and that alternative payment model needs to infuse private dollars into social programming from which the investors have an opportunity to benefit. I was meeting with a gentleman in Boston who has successfully done this work and is looking to expand into New York, looking for some models and opportunities.
Yeah, I would just pick up on that, and to pick up on the theme of just how big a difference this is. And I think it did come up earlier today too, just in passing, but think that 15% that managed care organizations could spend on non-clinical services also included all of their overhead. So,
And their bonuses.
and their bonuses. So it effectively included the possibility of a community-based program, but a social service organization invoicing managed care, invoicing a health plan for the work that they're doing. That door appears to be open or opening, and if there's some politics to be sorted out, is as big a change as anything that's happened in Disrupt in New York State so far. What that can do is to create a structure, again, where organizations can not only receive credit, but can receive funding for the work that they're doing anyway because of the impact that it has on the health of their clients and ultimately the cost of care for those clients. I think, so just a huge positive in that, huge investment in this space. Huge positive in that it's moving ultimately and finally in that direction. I think the shortcoming to date, to the extent that there's been one, is that it's been super hospital-centric. That it's, again, it's like, okay, so the idea is to keep people from needing clinical health care, keep people out of hospitals. Let's give $8 billion to hospitals and have them administer all of those funds and decide everything that happens with all of those funds moving forward. But they're really important actors and they should have a say and they should receive probably a cut of this. But making exclusively the decisions from enormous health systems that have a pretty narrow band of interests is something that I think has slowed the process, and I can speak offline and will probably speak more fluently, candidly, but has certainly had an effect on how Disrupt has played out to date. And I find folks on the social service side perhaps more disengaged than they ought to be.
100% correct. I think even as community-based leaders, we have to become much more bilingual. From a historical perspective, when you talk about social need and get people to feel sympathetic and they should be doing this for the good of the people and government should step up because government is our safety net. Well, let's talk about that thought process, right? There are people that could care less about any of these programs that we're talking about because it doesn't impact their day-to-day life. But if we want to onboard those people, because we do need their support, we have to talk about investments. We are in a capitalist society. We have to learn not to be afraid as community-based leaders to speak the language that the power brokers speak. We have to talk about that $24 billion that the controller was talking about. We opened so many doors talking about how Long Island is losing $24 billion because of racial inequity. Then they wanted to know how. How can we recover $24 billion? There wasn't one county exec that didn't give us time to explain, if you close these racial gaps, these people will then be able to become contributors to the community and not a deficit to the community. They can buy a house, they'll pay property taxes. And now the dialogue is open, but it's on us also internally to be able to speak the language to a broader aspect of the community to get buy-in.
Definitely, I think there needs to be that continuous communication between all the sectors in order to be able to find common ground.
I'm just going to say, I agree with you, Teresa, but I also think it's important to distinguish between real, authentic investment and rhetorical kind of communication, right? That to make ourselves feel good that we're doing community engagement versus mobilizing real resources. So, for example, we're in 4 PPSs as a small community-based organization in New York City. And we had every single one of those PPSs run a different program just for asthma, just a single disease. So we were running around as a CBO, plugging into different systems and having all this friction and transaction costs. We also have health plan partners. And when we go into the office of the health plan, we pitch them with data and analytics because we're sophisticated about that. And we speak the language of business and we get a contract, and we are now 85% earned revenue generating, rather than relying on philanthropy at ARNYC. All of that said, we can't marshal the resources that we in fact need to do the work, so we run those at a loss, and then we have to fill the gaps. When New York State first required the managed care organizations to work with Tier 1 CBOs, which is what we are, non-Medicaid biller, they required an MCO to work with one CBO for one issue, and made no requirement as far as how much money would be spent. Okay, so that was not a real requirement. I realized that it was a movement forward from what existed previously, which was no requirement and no acknowledgement that there was a social sector or any community-based organizations out there. But that's an example. Now, I think we're moving forward from that, and in the next round, there's a new payment stream opening up for this kind of work. But until we see the state require MCOs to in fact spend, specify the amounts of money that need to be spent, we're not going to see real investment.
So you're thinking some state mandates, maybe, related to the managed care organization?
For example.
Otherwise, the change is so incremental, it's almost not moving at all. What other policy changes do we need from the state? What else would make a difference? Like what Shoshana saying, contracting across the social determinants of health. We need things here on Long Island that are to be with a coalition like Healy, where we're able to work together to address those. But what else?
Right. And in the city, we have something called Communities Together for Health Equity, which Emily and I have spoken about. Similar sort of the CBO communities trying to organize to have more negotiating power with the state and with the plan. So we're seeing some of that happen. Also organizing through IPAs. I think another area where the state can be very helpful is around data sharing. Yes, we have the Shiny and the HIEs, now the QEs, and so those are there, but we haven't seen enough engagement from providers, from health systems. In the 4 PPSs that we're working with, which include Montefiore, Mount Sinai, One City Health. I mean, these are all New York City-centric PPSs. You may not know of them. The other one is Community Care Brooklyn. Everybody's on a different QE, right? So we have to consent for all of that, and the QEs don't really talk to each other, and we're supposed to be able to go above board to, through the Shiny, but it's not quite functional yet, and so we don't have those tracks in place, like what Steve's company, what Unitas is trying to work on to connect us, at least, the technological side of data sharing, that also protects people's privacy, because we know that people have fear of their data being, shared. So, I mean, a bunch of different ways I think the state can be helpful around data sharing.
What I'll add to that, and I don't know if this is a state change or not, a policy change, or more an interpretation change, is we also need to be careful what we wish for when we ask the state to mandate things, because 99.9% of the time it's wrong, or it doesn't get implemented the way it was originally intended. So part of that is using your voice in the community and raising your voice to be heard. The other is to not ask for the state to be really prescriptive, and learn how to read the language and apply it to your own personal, your own organization's benefit. Because I agree that the identification of one CBO that focuses on one chronic disease is like a disaster, but altruistically, their intent is different than how it rolled out. And one of the things that I noticed in our community is, and like Teresa, what you were saying is, until it impacts you, a lot of times it doesn't really initiate an action. So we've used the managed care organizations kind of as a chess game of sorts, where one, it was like, oh, this like CDPHP in our area is investing in housing. What are you going to do, MCO number 2, right? Like, look at how progressive they are. They really care about our community. And then what are you, and it started to follow up conversation, and they started to invite our organizations to the table and really talk about what were some solutions that they could in turn invest in.
Okay, I think we're going to open it up for questions now. Are there questions?
We know that we're between you and what's outside.
Any questions? Oh. Hi. Oh, wow. Sorry. Thank you. Thank you for the panel discussion. My question again is going to be about education. Again, my name is Dr. Sabrina Oliver. And in terms of equity, I want to focus on Long Island, but if there are things that's happening in the city that can help, I'm just wondering, Ms. Sanders, if you can probably speak to some of the efforts in terms of a brighter future for Long Island in terms of those racial gaps that you spoke of that are very real. And just knowing that in many of the school systems here, we have 124, right? Just talking about public education, that it is a disparity in terms of hiring. There is, I will tell you, I teach engineering also. I'm the only one that looks like me, including maintenance. There's no, so there's that. So I'm just asking, what efforts or how do you, as the Urban League organization or any other organization, really bring up that conversation that equity in terms of for education, it also starts with hiring. It's very important for students to see, all students to see different people leading or teaching, and I'm just wondering about some of those efforts. Thank you.
There's some great national models. We just had a really robust discussion about an article that came out that talked about false narratives and how many community-based organizations have built their missions around these false narratives. There are more black boys in jail than in college. And some of this stuff is not statistically proven, but we keep repeating it because it brings funding, sometimes sympathetic funding. But what we're doing now is, especially when you get to look at models outside of your immediate area, there are some pipeline programs have been very successful. So many of the successful pipeline programs are exposing young kids. It might not be a school curriculum model, but Jeffrey Canada used one when he created this whole ecosystem in Harlem. And he says, I didn't develop anything new. I used all existing resources in Harlem to change a community. I connected the karate school with the daycare center, and then connected that with the after-school basketball program. He just connected dots of what already existed within the community. And sometimes we approach community-based services from a deficit model. Oh, this is what's wrong with our community. How about this is what's right? And how we can replicate those types of models. Number two being the mentoring and role modeling type of program. And I think that very often we've become so sophisticated that we got to develop and design a program for everything. Well, there's always someone successful. There's a teacher that lives down the street from you that nobody talks to. You get in our cars and we pull out. Well, when the sum of that teacher is off, how do we integrate her as a role model into the community? Have her come to some of the after-school activities, or him come to the after-school activities. How many young people know that you're an engineer? Like, how many people know you have that science background? So these are the types of things, again, communication. How do we get information out there? It's all connected in terms of building good models.
And if I may, I started my professional career as a teacher in the South Bronx at Martin Luther King Boulevard, 172nd Middle School. And that's actually why I got into healthcare, because the majority of my classes while I was a teacher ended up doing really well, performing well on tests, but I was placed into what was considered a failing school at the time. And the only thing I did different probably than what they taught me in school was that I addressed, or I on a daily basis and got to know them and earned their trust, and connected them, helped to connect them to the necessary resources. Almost all of my kids suffer from one or more chronic conditions, and one of them being trauma. Back in my community now, I would say if you have an FQHC, a federally qualified health center, which is a clinic in your community near your school, they are literally the best organizations that exist, that are able to connect to cross-sector organizations and agencies. We have a lot of activity, dental, trauma-informed care, mental health services. So they're providing these services to the school and generating referrals from the school. And if you can help with those needs, then a kid can actually engage in their education.
We would agree with our chair of the Health and Wellness Council of Long Island is the CEO, president of the Federally Qualified Health Center on Long Island. It's absolutely true. Are there any other questions? Okay, I want to thank you all. Oh, can we take one more? Okay.
Hey, Alex Horowitz here. Thanks for the panel discussion. So the last panel right before you were a lot of local government representatives, folks from the counties, and in your panel we heard a lot about the state and what we done at the state level. I'm curious, how are you working with your local governments in Albany or in the city? I'm actually really curious about this. And if you're not working with them, there's a barrier to them, sort of working with you and helping in this, sort of quest for better health equity. What's the problem? Why are they not engaged?
Well, these are new concepts for Long Island. And one of the things that we're doing is using a model that was developed in Fairfax County. They got their local government to sign on to an equity resolution. So all county contracts, all employees have to understand what does equity mean. It's a very clear definition, and it's not ambiguous. But that's one of the things that we are working with them. The first point of contact are the county execs. Because once the counties sign on, and again, Long Island's complicated, we got villages, towns. We hope that once we get the counties to embrace an equity resolution, that everybody else will follow suit.
One more person, one more?
Sure. Just to add on a little bit of experience from New York State and from a few other places as well. Found that it really varies. Whether something is a political priority, what political leaders at the municipal city level want to do, want to stake their reputation on, want to invest in. I mean, the obvious difference between state level politics when it comes to health equity is that Medicare and Medicaid are flowing through the state. So there's this tap of resources that can be a huge vehicle for change. In Louisville, we found huge political willpower behind, not just what the sort of bully pulpit for what the mayor can do or what the city council can do, but in corralling the managed care organizations, and corralling the school district, and corralling the healthcare providers and the social service providers in the city too. Rochester, a huge investment from city government in terms of political will and resources as well. This all presents a big challenge for Long Island, and it's something that hasn't come up in our panel today, but in some of the very first conversations I had with Emily and with the team at HWCLI, is Long Island is long, and there is no metropole. Right? And I think it came up, I'm sure everybody in the room knows the stat, but it was new to me, which is that there are more folks living in poverty on Long Island than in Rochester, Buffalo, and Syracuse. Not something that you read about downstate, not something that is a headline or an impact. Blew my mind. There isn't the bully pulpit of a metropole, of a very large city on Long Island to push that agenda. Nor is there that gathering force for a metropole and sort of the towns around it to garner momentum. So I would say it's important absolutely to engage at the city and municipal level. I see on Long Island a path forward, probably one that's more both grassroots and comes from, in some ways, maybe outside of government, whether it's from the non-profit sector or even from the profit sector.
Yeah, I think that will be, that's what we really built with Healy, where the strength of all of our agencies combined is really really what's going to move this through.
Yeah, I was just going to add quickly, I think we can't wait for government. I think it's, bring the government along with us and, have faith in the community-based organizations and the markets to the extent that we can, and we'll move faster.
Yes. Well, thank all of you for your input, your experience. We really appreciate it. Thank you to everybody.
Wow, what a day. I want to thank our panelists, our keynote. I want to thank each of you for coming here today. We have our work cut out for us here on Long Island. I am reminded as I listen to the conversations from today about the importance of being counted, as our controller said in the 2020 census, we're 10 years of funding for children's health insurance and Medicaid, and all the things that we care about across health and human services are determined by a single count. And we know an undercount nurtures segregation, so I ask each of you to remember that as you go back to your communities. I'm also reminded that we joined together today for a brighter future for every Long Islander. And if we recognize that what happens to a child's life in one community impacts that child and that family in that community, but then it also impacts each of us, then we can say stop the madness and build the innovative infrastructure that we've been hearing about all day today, where we are able to see and serve and honor all of our neighbors. We are losing precious moments each and every day and every year to create a system that promotes equity across all of life's measures. Equity doesn't mean that everybody gets the same thing. It means that everybody gets what they need. If you're honest with yourselves, you know that there is much inequity that every single one of us has become passive about. We see that there was a shooting on TV, for example, and we hear that it was in a community that struggles with violence, and we often don't humanize that story. We don't think of the family that was just shattered or the life cut short. What do? We change the channel. We flip to Twitter. We tune out. We live in an era of tuning out, and it's time to tune in. It's time to believe for a paradigm-shifting change. Together, I promise you, we can stop the complacency. We can stop accepting the notion that any life is without promise. We can raise all boats, and we can live in a region where each person's promise can be realized because opportunity abounds. So sometime in the next few days, within a week, you will get an email from my office with some concrete action steps. Please, I ask of you, we need each and every one of you. Be an upstander for every community on Long Island. I know you are as moved as I am by today's presentation, and I really do know that together as America's first suburb, we can lead the nation on what it means to solve complex problems and actualize opportunity, hope, and promise in each and every community. So I thank you so much for being here today. Have a wonderful afternoon.